Now he has completed diploma in neurology from neurootology from UK, speech care in Odisha, and visiting faculty and different professional institutions throughout India and
gateway, and now we are searching for a hunting for the BPPV, all different kinds of research. And today I am just sharing my ideas, what I am doing, because I am a medical practitioner. So basically, electrocochleography is a test. All audiologists are thinking that only in case of Meniere's disease we are going to do electrocochleography. Yes or no? Yes? So we are limited to that. That's why most of the Indian scenario I have seen, people are not interested to do electrocochleography. First reason is that it's costly, that electrodes are costly. And many doctors are not recommending electrocochleography on regular basis, the way they are recommending audiometry and parametry or impedance. And second, most of the audiologists, they gave me feedback, sir, I have ecology, I am trying to do, but I am not getting satisfaction that okay, is it a good way of morphology or not. That's the problem, always. So they are not taking interest to do in regular basis. As they have not no confidence, so they are not sharing their ideas to the ENT also, sir, please send to the patient because I am doing regularly. That's the more problem. So in this audience, how many people are doing electrocochleography? Anybody is doing? No. Okay. So I will not go through the theoretical things. Many people, they have read books or they have attended some lecturers. Theoretical, maybe you are well aware about electrocochleography. I will give you some practical inputs what I faced the difficulty when I started doing electrocochleography and how I am doing this in easy way. In giving some example, when the real ear measurement was the hearing aid fitting instruments when we were discussing in our PG level, UG level, I was thinking, oh, it's so tough. Who will purchase this equipment? Why will we REM for the all hearing fittings? But nowadays, I can take the name also, Dr. Vikrant Patil. He simplified in simpler way that REM is nothing, just a 5 minutes procedure you can do each and every patient's for hearing fitting. The same way, we have to take a home message that how to do this test. We are very good on interpretation on that part. Only the procedure, as I said, cumbersome procedure, sometimes we are facing, who will clean this, who will do this, all these things, and the gold electrodes will vanish, nothing is not coming, the impedance is not coming properly. So we are not taking interest. Okay? So this completely 40 minutes or 30 minutes, I will share with you the clinical aspect, how to do this test rather than the theoretical test. Okay? So what is electrocochleography? Anybody?
Regarding the cochlear activity.
Okay. So simple graphical representation of cochlear physiology by putting electrodes. Simple. Okay. So as electrocochleography, we know that this is an early latency response, like ABR, or part of ABR, or part of auditory potential. So or it's coming less than 2 millisegments, very early response. So we have to be so careful when we are doing this test. Okay. Next. I've already told about this. This is when you are actually trying to get the cochlear potential. Now, cochlear physiology. Your UG level physiology, just try to revise. What is that? What is cochlear physiology? Cochlea act like a microphone, right? Because video act like a transformer. Then after that, the cochlea act like a microphone. So first there is a cochlear microphone. First cochlear microphone. Then after that, the sound will go to the hair cells region. Due to the hair cells movement, there will be another potential called somatic potential. And after that, the auditory nerve will catch those signals. That is the action potential. So three things we are going to see in our electrocochleography graph. First is cochlear microphonics. Second, somatic potential. Third is the action potential. Clear? Now, first, cochlear microphonics. So it is a alternating current voltage that reflect the instantaneous displacement of the basilar membrane. So when you give a sound, first sound you will give the first movement of the basilar membrane, which happens in the basal part of the cochlea. So that's why it's called very early. So the cochlear microphone is like a, you can see it's like an artifact. It's like a small sinusoidal waveform, small kind of artifacts. Okay, and that is recording within the cochlea. The method is recording and the stimulus conditions. What stimulus you are getting, according to that you will get. Okay, and as you know, in Vera we are using three polarity: alternating polarity, condensation, and the reflection. So what stimulus you are giving, what conditions or polarity you are using, according to that you will get the cochlear microphone. We'll see. Okay. Next, it mirrors the waveform the acoustic sieve stimulus at low moderate level stimulations. It's generated predominantly by the outer hair cells of organ of Patae, as I said. Reflects basal end of the cochlear activity when recorded from the round window and more remote sites. You can put any electrodes at the round window area or promontory area, you will get a better. But as a audiologist, we are not doing any invasive procedures, we are doing extracting money. Now, if you see here, the first rarefaction and condensation, if you do that, you will not get the cochlear microphonics easily because cochlear microphonics and somatic potential, the values or the areas are same, the latence areas are same. So where you will not get, there you will get only action potential, here you will get only somatic potential, and if you do only condensation and rarefaction, then you will get cochlear microphonics. If you do alternating polarity, you will not get cochlear microphonics. So most of the times what audiologists believe that, sir, I did 3 times recording, 4 times recording, microphonics is not good. No. So you have to do condensation 2 times, rarefaction 2 times, alternating 2 times. So 6 times. Okay? Then you can see the waveform replica is there and alternating polarity is giving somatic potential and action potential. Rarefaction and condensation is giving cochlear microphonics. So all 3 things you have to see. Now somatic potential is a direct current DC potential sit in the cochlear microphonics baseline. As I said, where the baseline starts, cochlear microphonics, same area you will get the somatic potentials. Okay? And it is also generated from the outer hair cells of the organ of Patae. Same, only somatic potential is direct current and your cochlear microphonics are the alternate. And the last part is action potential. Action potential is a alternating voltage, alternating current. The action potential waveforms are characterized by a series of brief predominant negative peaks representing the distribution of underlying neural firings. When neural starts firing, when the neural starts getting information from the cochlea, then the peaks is coming as negative or positive depending on your stimulus, and that is called action potential, which is otherwise called the first peak of your Vera. Vera first peak and electrocochlear peak, action potential C. Now, action potential is most often generated by click stimuli clinically. That doesn't mean that if you will do tone burst also it will not come. It will come, but click stimulus give you more clarity, more enhanced picture. Clear? Now coming to the part of methodology of recording techniques. We are using two techniques, extra-tympanic mode and intra-tympanic mode. Extra-tympanic mode divided into two types, tipped rod and tipped rod, and intra-tympanic mode is needle electrodes. Okay? So when you are doing intra-tympanic mode, which is best way, most of the UK people are believing that. In India, I think very rare people are doing it. You need a surgeon, ENT surgeon along with you, and it is an invasive procedure. So most of the times we are not doing clinical. But in extra-tympanic mode, we are using tipped rod and tipped rod. Tipped rod is like a gold foil electrodes, which is placed on the ear canal, inside the ear canal. Whereas the tipped rod you will place near to the tympanic. So which one you are using? Tipped rod. So you are getting good work from morphology? No. Sometimes you are getting, sometimes you are not. What are the limitations for this? Why are you not using this one? This is for availability issues, not available every time, and also cost matters. One electrode costs around 3,000 rupees. 2,500 to 2,000 rupees. So two electrodes will require for one person, so 6,000 rupees. How much will charge for the patient? How much will charge the patient? Patient not going to give you 7,000, 8,000 for one test. And second, if a doctor will write also, commercial point of view, you are zero. That's why people are not taking English. But this is a beautiful test you have to do on the needles. People are saying Meniere's disease diagnosed clinically from the history, from the audiometry. It's okay. But you need a pinpointed diagnosis by using electrocochleography. Along with nowadays we are doing vestibular potential. I think Dr. Suresh now already explained yesterday, like how to get different wave patterns in Meniere's disease. So that is good. If you have wave but you don't have epoxy, you can go for heavier pitch audiometry and your wave test, C-wave and wave test. But if you have and you want to publish the literature, if you want to do something good work extensively, I'll go the clinical applications also. So if you have that idea and that instrument with you, please do it. Unless until you will not do it, gradually people will say it is not nowadays used clinically. Electrocochleography not used nowadays. Many states people are using regularly your CP and RCP, CCTDT regularly. Some people are believing right now, no, those tests are not required. Okay? So if you do practice, you will get confident. If you will not do, you will not. That's the case. Now if you are using tipped rod electrode, this is intra-tympanic, the needle electrodes. Simply, if you have AVR equipments, you change the settings, parameter setting, all these things, you will get the things. That's all. All else, if you have a good standard equipment, all those manufacturers or those people those are providing that equipment, they have some by default settings also according to their instrument. It will be okay. So either you will change the setting parameters, if you have that knowledge how to change the stimulus parameters and everything, you will get. Otherwise, by default settings also sometimes you will get because they have developed that equipment according to that by default settings. Okay. Now, where to place the electrodes? Okay, simply I can say go for single channel. If you have double channel also you can do, but go for single channel. So positive electrode inside the ear canal, negative electrode on the opposite side, and your ground is on the foot. Simple. If you are doing bilateral, then you have to do both the sides. Then you need 5 electrodes. If you don't have double channel equipments, go for single channel. And filter settings. the stimulus parameter. First is transducer. Which transducer is good? Headphone or insert earphone? So don't need to discuss all the theoretic stuff. Next, type. Which type of stimulus we are going to give? Stone watch also you can do, but if you are doing this purposes, you can do. Clear? Intensity. High intensity. Because always your meningitis will be moderate level or mild moderate level hearing loss. So you will go for a high intensity, 90 NHL, 95 NHL. Red. 11.1, 33.1, 99.1. That we should discuss. Okay? Some studies they say that 7.1 will give more robust peak. And some people they say that less than that 7.1 also you can go for that. But beyond 7.1, if you go 11.1 or 99.1, more higher rate, the waveform morphology will not get a clear distinction. Okay? We'll see. Next is the polarity. Which polarity will we use? All. Alternating polarity is for SP and AP, and rear fractional condition for ocular measurement. Very good. Now see, 7.1, you are getting a nice picture, nice waveform morphology. When we are going 47.1, 87.1, the waveform morphology are not good. Clear? Easy? Now 7.1, clinically you have to use the right and all three polarities. Now, as I said, if I go for alternating polarity, your SP and AP is coming clear. If I am going single polarity, like condensation or rarefaction, then you will miss your SP. Because at the SP area, what you will see? Cochlear. So once you give rarefaction, it will be negative peak. Then condensation is a positive peak, and other way morphology are same. That area, the negative and the positive area is called cochlear. Accretion parameter, analysis time. As I said, very early. So the derivation is up to 3 millisecond, 5 millisecond, not beyond that. Why at 5 millisecond? 5 millisecond also you are getting the first, third, fifth peaks around. Filter setting. Low filter settings are always better than the high filter setting like better. Okay. As I said, latency analysis. First, interpretation, latency. Second is amplitude. Third is SP and AP, amplitude ratio. Nowadays, fourth interpretation is your area of SP and area of AP. Four things you will see. First, latency. So the AP latency range from 1.3 to 1.7 millisecond. As of Vera also, first peak is coming in that range. So first peak of Vera and same our action range. Clear? Then amplitude, SP and AP magnitude ratio for peak stimuli ranges 0.1 to 0.31. In which condition? Transtympanic. Needle electrodes. But when you are using the Lilly electrodes or the tympanic membrane placement, it should be less than 0.45. If it is tipped rod, then the normative value differs. It's 0.50 to 0.55. Depends on your normative. But we are using tipped rod and expecting 0.45. That's why I have seen many reports people are writing Meniere's disease. No, your normative is different. You are using tipped rod always. Many people are using tipped rod, gold foil electrodes, and they have read in literature that 0.45. If it is more than that, then this is Meniere's disease. People are writing Meniere's disease. No, your normative is 0.50 to 0.55. Clear? Now, okay. As I said, these two things are over. Area under the curve. Area under the curve. What area? SP and AP area. We'll see. Not available in many equipments, but nowadays it's available with the ISHA intelligence hearing system and also many because we have no idea. So this is the base where the waves starts here. This is SP and this is AP. So we will put all these electrode placements there, and the amplitude will measure. Automatically we will put the base. The instrument algorithm will measure the SP area and the AP area. Okay. So in intelligence hearing system, what they are saying, if the area is more than 2, then it is said abnormal or linear or endolymphatic kind of suppression. How? There is a research that people said that in our cochlea 0.07 microliter endolymph. Okay? If that increase by 0.02 microliter, that means 0.09, then all these disturbances are coming. Tinnitus, hearing loss, oral vomiting, vertigo. So only 0.02. So this system says that 0.02 milliliter converted, they have area given 2 milli. If it is more than 2 milliseconds, then it is called linear or endolymphatic. We'll see the abnormal patterns. You will see here another graph. This is the area ratio is less than 0.1. This here it's normal. If that SIG2 was more and the area will show more, then this is called endolymphatic hydrops or meningitis. You can see in this graph, it's old graph actually. Here, how to measure the area of SP, how to measure the area of AP. Now, the main point, clinical applications. Why I gone so fast? Because if I go one by one sentence, like theoretically, you will feel bored. What Hallowell is developed, how the cochlear microphone is developed, all these things are not necessary. We will know what to do, then how to do, what parameters we have changed, what to get, what clinical application. That is very important. Okay, that should be our take-home message. First, assessment of peripheral hearing loss. Yes or no? One we will discuss. Any peripheral hearing loss, it will do electrocochlear. If it is present, it's normal, you can diagnose the patient. Functional patient also you can diagnose. No, there is no functional abnormality. Even if you have OAE, but still you can do electrocochlear for that purpose also. Second, enhancement of ABR waveform 1. Auditory neuropathy cases or other cases, you want to see the enhancement of only ABR 1. As I said, action potential is the first peak of the bearer. You can see nicely. Third, detection and diagnosis of auditory neuropathy spectrum disorder. Yes or no? Yes. You need bearer, sometimes absent. You read theoretically that okay, the first peak will be present, then other peak will be absent, but it is not true in every time. Sometimes all peaks are absent. But if you want to see exactly what conditions your OE is showing past or sometimes refer also, but you want to see, then you can do a electrocochleography and get the better idea. It is a case of auditory spectrum disorder or not. Next, intraoperative monitoring of cochlea. Many skull-based surgeons are actually lateral skull-based surgery. They are touching all the area of the cochlea, all the nerves and things. And sometimes any kind of, suppose vascular schwannoma, now you can say vascular paroxysmia, some cases people are trying to remove that particular swelling structures, or you can say the schwannoma or the tumors. That time also as a audiologist, the same way we are doing cochlear implant surgery, we are doing mapping and all, same intraoperatively you can check, sir, cochlea is intact, no harm. So, but people are not doing it intraoperatively. ENT people are not aware also that that could be used in intraoperatively. If you have that electrodes, little electrodes, go to the your ENT, tell, sir, you do your surgery, at the same time I can check after the surgery, cochlea has perfect or not. Because vestibular sonoma, they removed everything and they are telling, no, all hearing part I cannot assure you, it will be intact or not. But if you have that facility, you can tell, sir, cochlear damage. No. So you can counsel the patient at this time. So intraoperatively also you can use this. Next, diagnosis of Meniere's disease and endolichocardiosis, our main motto. Differential diagnosis of Meniere's disease, vestibular migraine, third window syndrome. What is third window syndrome? Semicircular license, perilymphatic fistula, and enlarged vestibular aqueduct syndrome. These are coming on the top of third window syndrome. So nowadays, some researchers are saying Meniere's disease, your electrocochlear will be absent. At the same time, in third window syndrome also, your electrocochlear will be absent. But in vestibular migraine, it is present. Why I am telling more again and again? Many people they believe that sometimes migraine and Meniere's symptoms are same, only irrespective of hearing loss, others are same. But some people's hearing loss is also there. And you don't know that hearing loss is for what? It is automatic level disorder, it is what? I don't know. It is past history. But still, by looking at the audiogram, oh, this is Meniere's. No, that would not be Meniere's. The hearing loss is long ago, but now the symptoms is coming as vertigo. So, to make a differential diagnosis between vestibular migraine and Meniere's, also this electrocochlear helps a lot. Next, very important, monitoring the effectiveness of treatment. Many doctors, yesterday one conference was there, many doctors they asked me, tell me how you are dealing with this Meniere's patients. They will go, okay, you diagnose the patient Meniere's, we diagnose the patient Meniere's, how you are going to take a resolution of this patient. Here will help. I told 50-50, 60-60. Sir, this is the only one condition. Nobody knows what's to happen to this patient. After doing everything, again the episodic attacks came and again that same symptoms happens. So we don't know what happened to the patient. But the effectiveness of treatment. Suppose they have given medicines. After that they have given some steroids. After that they have given some gentamicins. Or after that they have done for vestibular neurotomy. The steps of Meniere's treatment you can monitor by doing the electrocochlear. What are the stages? Okay. Next, used to measure TTS, temporary threshold sleep. As you know, 80 dB sounds more than 7 to 8 hours you will hear. You know what happened? Temporary threshold sleep. That also you can monitor by this electrocochlear. Last, used to make decision-making treatment of differential diagnosis of Meniere's disease and vestibular migraine. New things, I will show it to you there. It's a research done in USA. They have done that. They thought Meniere's and migraines both have same, and based on their treatment, they decided that okay, now this is the patient for Meniere's, this is the patient, right? But later they conclude that no, our electrocochlear helps a lot to understand. This is a case of vestibular migraine and this is a case of Meniere's disease. So, as I said, the differential diagnosis helps a lot and effect of treatment. And you can counsel the patient according to that. So, this treatment has given, now your cochlear part is okay, don't worry. We'll see after that what is happening to the cochlear. Now, otherwise, every time when you are counseling, sir, after giving gentamicin, you are hearing loss. The patient says, okay, no, don't give. Because you are not counseling properly. Okay? And as a ENT surgeon, they don't have time. All these things to explain sometimes. As an audiologist, you have to have that knowledge. Pre-counseling should be done by the audiologist. Then doctors will, that's why it's a good team. You need a good team. The doctor should believe on you that you have counseled properly, then go for the surgery. As for the gentamicin therapy or the dexamethasone therapy. Okay? So as an audiologist, you should understand what the treatments of Meniere's disease, what is Meniere's disease, how to diagnose the Meniere's disease. Only don't believe that electrocochlear is only for Meniere's disease, rather than all these clinical applications. If you want to explore, you can explore. Only the part is money. Slightly cost effective. That's why people are not taking interest. But once you do, you will enjoy. When I started also doing this tympanic membrane placement, I thought, okay, 4,000 gone. How much I am getting? I am not getting 1,000 also. I will not do. Even I am not getting 1,000 also, but I am doing regular. So what benefit I am getting? I am getting confidence day by day. Okay, this is the patient. I did this. Benefit is another part. We are doing commercial business. We are doing clinic, running clinic. That is one part. But the second is, I am not telling each and every patient how to cochlear. When you see each and every reports, you are not getting any clue. Everything is showing normal, everything is showing abnormal. I don't know what to do in this patient. That time, if you are thinking this is veneer, this is migraine, this is third order syndrome, I am very confused. I have no radiological report right now, no CT scan, no MRI. So please, you can explore the knowledge. Why I am telling again and again? Many audiologists they told me, sir, Bera cytometry test I have never did in my life. Because MRI is there. Nowadays MRI is easily available, people are doing. But still we have believed that our Bera is so sensitive to catch the vestibular schwannoma. Less than 1 mm also can catch. But we are not habituated doing it. And we are not poking in our ENT mind, sir, please send us the patient first, we will do ABR cytometry test. Then you can send the MRI, no problem. Because ABR cost is around 2,000 rupees, 1,500. And you can go for MRI for 8,000 and 8,000 because they are doing some medicines after that 1 hour they will do that test, right? Contrast MRI. So that's why, as an audiologist, the take home message is electrocochlear is very important. Now you have to add on to your battery. If you have them, you have electrocochleography with a good audiometry and speech audiometry, then you can conclude that this is purely a case of veneers. This is a purely case of alternative nervous spectrum disorder, and different third order syndrome also you can explain. Clear? Now you can do? Yes, sir.
Sir, in case we identify again for treatment wise they need to undergo scans.
Yes. After giving treatment, suppose doctor is giving gentamicin. After gentamicin, you can go for electrocochlear consult. You can go.
If they are received, they can't treat. So that's why the industry ultimately saying.
Yes. So periodical monitoring you can do. So you will have a guideline, okay, before gentamicin this was the cochleography, after gentamicin this is the species. Sometimes will not get SP, sometimes will not get.
Madam is talking about schwannoma, vestibular schwannoma.
They will call it as complementary ultrasound, so the report is coming. They have got their money with the with the CT scan, they will do it. Somebody is sent for an MRI. If everything is not clear, some bony details cannot be there in the MRI. So what they will do a complementary CT scan. If any person comes to you for a pure audiometry, and if you see a asymmetrical hearing loss by the definition of asymmetrical, or if you see a unilateral sensory loss, you should not be sending back the patient just like that. Even if it is sudden also, you should not be sending. You should be doing an ABR and then only sending. Now whether you convince the patient to pay the additional money to do the ABR or how you do it, you want to do it complementary, whether you get all of this. Why this is important? For me, I can say, okay, if a tumor is there or not there, on MRI I will come to know why waste the money on APR is the next question. Okay. So now, whether it's a waste of money or not waste of money will depend on how much you are charging. Okay, will depend. Now, MRI is not something that is simple and straightforward. First and foremost is to go into the MRI room. Okay, is a really bad experience to even for a normal person also. Being there in the MRI console for half an hour, you ask anybody who has gone through MRI, they will tell you, being in the MRI console for half an hour is like very claustrophobic. It's not easy. So even if you write, the patient will not go for it. To that extent. Second thing is, the moment it is MRI costs somewhere around 7,000 to 8,000 rupees. So I will also think whether I should go or I should not. Either I should go or I should not go. Third thing is, even if I do an MRI, I will still miss 0.1, 0.2, 0.3 mm vestibular schwannomas if I don't do with contrast. The moment I give contrast, you are getting the thought process. If I give contrast is not a danger. There are some people after contrast have their reactions. There are some people who have gone through renal problems, long-term renal problems.
After one contrast administration, that is okay, a kind of fibrosis that happens after contrast administration. Which means, if you get by ABR, after doing your ABR, you can tell me this patient shows a very high possibility that there is a recovery conscious after your ABR. Then I will be convincing only those patients for an MRI with contrast. Rest of the people I will not see. When I don't send the rest of the people, I am saving so much of money for the patient, not sending for MRI. Second thing is I am saving so many patients' kidneys. If it's quite safe. But then there is some patients in whom when it goes really bad. And for that person it's 100% problem. It may be 1 in 10,000, but for that 1 in 10,000, one person, that's a 100% problem. But nobody would want to lose their kidneys to be sure whether vestibular schwannoma is there or not. Because a lot of people, the vestibular schwannoma will do nothing for them in their lifetime. Nothing will happen to them. It will not kill them. It will cause hearing loss, but it will not, beyond the hearing loss, it will not cause. For a lot of people, it just remains silent. It goes so slowly. So one of the accepted ways of managing the vestibular schwannomas is actually serial monitoring. Just monitor serial. So when you actually start doing this is completely. The person comes, the decision making at the audiologist level is very simple. Patient comes using a unilateral sensory neurotic loss, or your seat is asymmetrical hearing. Moment you say unilateral sensory or asymmetrical hearing loss, not afterthought, it should become a reflex. It should not be an afterthought, it should be a reflex that you simply do it. As a reflex, the moment you start doing ABR, then you start seeing, okay, it is there or not. And your ABR should be set up so nicely that you believe your ABR. That is very important. Because
if you do once more,
I can simply connect the electrodes to the sofa set, acquire, and then give it to somebody, and I will still get somebody marking the 5th peak for me. Very nice. You want? You can. If you want, you can. If you want to find something where nothing is there, also you can find. Because human mind is such that because this is not like the nystagmus where it is there or not. This is like so much in there. There are people who have picked up. I saw Swaroop, there was one ABR done for a baby. They told full hearing loss. He saw that and he told this is, moment he saw the waveform, he told this is not done correctly. This child is not. Child is talking nicely. They were working up a cochlear implant. This was in this thing, I took him, it was in Gujarat. We went to Gujarat. There was one guy who came, he also can do this, and he's gone to another place, he's got all the rest. Because he thought the child may not be hearing like that even. So Rupsa, he told him this ABR is not done well. It is not done well, and this, you remember, no?
Yes, yes.
Okay, because it not done well, don't do it. He told it is not done well. He went somewhere and then got it done. So this is the thing. But once you are sure of your instruments, about your technique and all these things, then you should be offering to patient. So please let us know the name. For every unilateral SNHL, it should be a rule. Like it should not an afterthought, it should be a reflex. Let it go, sir, please.
I will be presenting another case.
Absolutely. So, sir, will be the so like that.
Where there is no bilateral hearing,
Yeah.
no unilateral, bilateral hearing loss,
Yeah.
still my diagnosis was vestibular schwannoma of the left ear.
Yes.
Only on the basis of API. And later when we sent for MRI scan, it was 2 centimeter tumor in the areas. It was my diagnosis only.
Super. This is. You know, my idea of telling that you do an APR whenever you see unilateral is so that if a sir told like in the institute they do for everybody something, you are better.
Actually, like sometimes I see one patient actually in my easiest time I have seen. We did it there and it was that retrograde just showing. We told ma'am, sorry, ma'am, it's vestibular schwannoma. Then one of them wrote say was vestibular schwannoma. Then in department they did a simple earlier, not by AD. Some other department they have done. I don't know. Then ma'am told us, do it once again, we did it once again. Then send report. Then ma'am told, no, it's confirmed, it's vestibular schwannoma, you do not. They, after provoking so many things to our AD convince, they did it. It's beautiful came as a 1.2 action. Which may be not life depending at all, but as a findings, we got a satisfaction that okay, in our very so sensitive to catch the particular phenomenon. Okay? So you need a practice. As I said, sir said, we are clinical practitioner. I am also clinical practitioner, but you can ask her. Many tests are doing free of cost. Only to learn, only to get a comprehensive idea. What in this case, what to do, what are the findings. So if you are saying I am busy, I don't have time, to tell your assistant, they can do that. If some other audiologist are there, you can tell them, okay, I need all this recording beautifully, you have to record. Okay? Because recording can be done by somebody. And if you have home confidence, no, I have to do each and everything, you can know by that. Okay? Thank you so much.
So there are questions.
Yeah.
Thank you for your valuable inputs. Actually, this is what I follow, the complement test. If I get PTA from ENT, then I can do the impedance, sometimes speech audiometry also, with free of cost. I won't. Sometimes I will go with Vera also with free of cost, even though I am private practitioner. But I want to check everything. Okay. So at what intensity we can detect the, this Sanomanda. Suppose if it is there,
Only high intensity 95 dB or which will give you much more clarity on idiopathic sort of hearing class. So I will do audiometry, speech audiometry and hearing. If they are not convincing also, from your point of view, you do free of cost because you derive sleep.
Yeah.
So you do it and tell them, so this is the beauty of our sleep aid, that it's giving much more clarity on sort of hearing class.
And one more craze, I think it is down. So, is there any contraindication, like is there any misconception diagnosis of regarding OE in the objective tinnitus patients?
That is controversial.
Sir,
OE and objective tinnitus.
OE regarding an objective tinnitus.
I have never seen.
OE and objective tinnitus, there are a lot of confusions actually whether it is
tinnitus what is coming out, but it's basically the objective tinnitus is more to do with a vascular region and not the usual this one diagnosis, and you have very less cases of this vascular regions that you get objective tinnitus, and the microphones are very sensitive, so if the sound is obviously you can hear, it can detect that.
Good. Any question? No. Yeah. Everything is perfect. But still sometimes I have seen also, yesterday I did Vera was not good. I called the patient after 2 days, now my Vera is coming good. That is due to only physiological and wonder factor, nothing else. Nothing wrong with the instrument. No, because you have done OE, na, so all correlation you have done, and only Vera is affected. So doubt on Vera, and you can tell them, okay, come next time, once again, I'll do nothing wrong, harm in that. I'm doing it. Which cases? Children or adults? That may be autistic children. Autistic children, you will get beautiful morphology with high amplitude there.
Activity will be more.
one more reason is that if you have IHS,
it has got lot of electrical interference. Even the grounding is slightly high also, it gives you lot of artifact, and even though you have a normal subject, you might find that Bera to be absent. So just check along with the subject factor, you check the grounding of the connection which you have.
Bera is neurosoft.
Okay, neurosoft is okay with this one, but particularly we face this issue with IHS very often, that if the grounding is not good, the instrument will not give a good reliable waveform. That is the big problem which we face.
That is what we have to check. Because with the equipment, you just check that whether the grounding is also good. And someday when you don't get a correlation, someday you just, like yesterday, we tried getting web, we didn't get it. So
Yes.
just to back it, you can call the patient next time to be.
What I am doing, actually, I am removing all the clock spots, everything. Give some time, 1 second connecting each and everything. I don't know what happened. It's not instrumental fault. It's some physiological fault. I don't know. As sir said, some impedance mismatch happening, some grounding problem is there, some electrical aspects are coming. So that's why if you do more and more, if you do practice, you can have confidence and on your performance. Right? Clear?
Where is Maranika's name?
See, it's always. So, Dr. Srinivasara.
I will take a photo and send it to you.
Yes,
No,
sir.
I have already taken a photo, sir.
No more food for you.
Today you will be bonus for you.
Their contribution in my life. What I am today to do, them only. Always he is motivating me, do your best. And he is teaching each and every pinpoint with holding my hands. He never leave my hands till yet. Thank you. Thank you so much.
You tell them about the ISHA monograph chapter, no?
Yes. So, there are two books. First is ISHA monograph by Vestibular Assessment Management, 250 rupees. You can write to our ISHA. ISHA will send it to your home with courier charges. You will read Dr. Sujit, me and Dr. Neeraj and other few doctors also, ENT also. They have written some beautiful chapters. It is on vestibular assessment management. We have tried a lot to publish that in our Indian scenario. You can read that book. Along with that, if you want to a great extent on only vestibular evoked myogenic potential. Thanks to Dr. Sujit, the first audiologist to done a book publications in USA, no publications. He is the only person. So, in that also, we have written so many chapters, and it is on only him, history to interpretation. Okay, that book is available in Amazon. That book is available in slightly costly, but you can tell sir. Definitely, he will send the link, and you can purchase that.
The book name?
Yes, vestibular evoked myogenic potential. Fundamentals of vestibular evoked myogenic potential. Sir, Amazon is available. Okay, thank you so much.
Thank you so much.
Thank you so much for your valuable inputs and building up the confidence about cognitive. Now we can be very confident in talking about the patients and as well as students.
That's all good. Theory you can read your books, but the problem is that we will discuss, we will get the idea where you have some process like, okay, I'm not getting the peaks, I'm not doing this properly because I don't know the parameter settings and all. The parameter settings are very different. And an audiologist, you should understand what is the stimulus parameter, what is the acquisition parameters. That's all. Because all that epoxy, Vera, some people are telling neuro technicians are doing also in different colleges. You cannot challenge them. But as an audiologist, you can make an impact on that. Okay, the way I am doing, they can.
So in the three canal planes, when you see, here you see three types of graphs. Okay, there is a green line, there is a red line, and there is a blue line. Okay, the green line has been allocated for the horizontal canal. So basically, when I move the head in the horizontal plane, you see the green line is moving. Can you see that?
Yes, sir.
Okay, right. Can you see that? The green line is maximally moving. Okay? Fine? Now, if I move the head, now if I move the head in the LARP plane, LA means left anterior and right. Oh, this is we have changed the color. I think the version that I have is little black. Otherwise, it will be blue, but here in this graph, it is the red color. Okay. So here the red color is left anterior and right posterior. Right anterior and left posterior will be blue color. Okay. The last update I just changed this, okay, to make it left anterior as well and this as well. That's all. Okay. Only the color representation. So basically, what is happening here is you can be sure which canal is being stimulated just by looking at the graph. That's all. And when you make the test, it has to cleanly only move only that particular canal, okay, or that particular plane. Only then you will know. So what you do here is you hold the person's head and then you start moving in such a way that there the velocity graph is there on the top. Can you see on the top?
Yes, sir.
The velocity graph. So it has to move in such a way that when I actually see the move the head, it has to smoothly enter the green zone. Okay, that when it enters the green zone, that is the level at least, that is 150 to 200 for lateral canals. That is the level at which it becomes a test, exclusive test for the left-sided lateral canal. Okay. Why it can't be slow? Question. Why can't it be just very small, 50, 100? Is that right? Is that a question? Okay. So it can be like that also. So what is being tested here is when I move the head like this and go like this, like this, like this, when it hits the peak into the green zone, that is when the character will appear. I will show you the character appearing later. The character will not appear before, character will not appear later. What is the function of VOR?
Fixation.
Foveation is motion or vision in motion. Please remember this, semicircular canal. Don't tell balance that, this, all those things. It is vision in motion. Semicircular canal function is foveation, a vision in motion. When the person is moving, the person should get clarity of vision, means semicircular canal should function. That is the thing. After 2 days of here, when you go back, all that, if you learn that semicircular canal function is vision in motion, it's enough. You got it. Okay. The purpose of the visit is done. Is that okay? It's vision in motion. So, if the person can see when the head is at peak velocity, that means VOR is working. Okay. Because what the character will appear only at the peak velocity. Now, why can't the head velocity be slow? Why can't it be 50? Why can't it be 60? Is the question. Is that okay? So when an object is moving like this slowly, you can still see clearly. Is that right? Just hold your thumb there and slowly move it. Can you see the lines on your thumb nicely?
Yes, sir.
This is called, what mechanism is being used here? Is this VOR? VOR is vision in your motion, not object peaks after 60 to 80. Got it? Smooth pursuit fails after 60 to 80. So which means if you have to test exclusively the VOR, the head has to move above the level of the smooth pursuit. That is why that velocity is important. Clear so far?
Yes.
The next important point here is, when I am telling about this one, the next important thing is, see right and left. For both, you can see that, right?
Yes.
It's moving. Movement also. Is that right? Yugandhar sir taught you yesterday. It works, it moves. But right word saturates at a higher level, left word saturates at a lower level. That is what is happening. Because if you remember correctly what sir was telling, there is a baseline firing rate of 60 action potentials per second. When I move to the left side, that can go up to 0. To the right side, it can go up to 300. Clear? Which means the detection range for the right one, for right side is very high. Detection range for the left side is very low. Which means somewhere around 100, after 100, the left canal cannot take care of them. The left ear, left semicircular canal cannot take care of the visual stimulus. So from 60 to 100, up to 60 smooth pursuit is enough. 60 to 100, even one canal is enough. Because this canal for the left side also it will take care up to 100. This side also it will take care. Now what is our purpose as a clinician we are testing? Single semicircular canal you have to check. So you have to isolate that canal and check only this canal, means you have to increase the speed beyond that canal. Two principles. First principle is you have to increase the speed beyond the smooth pursuit so that only canals are being tested. Then you have to increase the speed even further so that only one side canal is being tested. Clear? And by moving in the one particular plane, you are only engaging that plane canals. These are the three principles. Okay? There is a small difference here between F hit and V hit in the technique. V hit will be hold the head like this. Okay? That is very fast. Okay? V hit will be without spectacles. F hit will be with spectacles. Okay? F hit will be with spectacles. The ideal screen should be at this level, at the person's eye level. This is not the ideal screen level, but that's okay. We try it. Okay? So, 4477, my man. This keeps, I kept it at never sleep also, it is okay. So that is the entire thing. Is that okay? So now, I will be looking there and I will be giving a stimulus. You can see what happens. Okay, we will start the test from beginning. Is that okay? So I will just stop it. Then you can see what happens. I have to relaunch this one so that the extended screen. I don't know what is the screen dimension. How much it is?
Basically, 50 by 60.
6 by 6 by 6. No, 6 by
I will start the test. So what I'm going to do here is I keep concentrating there. Is he has to see there. Then what I do, I make a slow movement of the head, take it there, and go back. Can you saw that?
Yeah.
Yes. So what it is? I or J. So, yes. Yes. You are testing for 4 years. So like that. The screen resolution I have not entered correctly, so some alphabet is getting cut correctly. I didn't measure it. What was that? C. You saw that? Excellent.
Let me do it.
No, you are not doing the test. He should see when his head is moving. When that appears. It appears exactly when the head is at the peak velocity. Okay, it does not appear when the head is stopped, this side or that side. That is the beauty of this one. Is that okay?
B, T, N, O, G,
Don't hold.
T,
Excellent. So you have to give the instruction not to hold.
C,
Yes. You make it easy.
J,
Yeah.
I,
Excellent.
N, F, L,
Yeah.
H, F, R, B, C, P, O,
So that is done. One.
What got
No, it is getting cut because the screen resolution is not entered correctly. That's okay. Yeah, right. So we make provision in marking it, don't worry. So what I'm doing here is like this.
Right, horizontal.
Right.
B,
So, I think you are internally, I think something you want to give less marks. Yes.
N,
See, you are trying to test a foveation. In this test, one more thing one more tip is, if you think the person has foveated, you keep it as right. So there is a D and O. People confuse D and O. That's okay. Because the person has foveated, you mark it as right. When the person has a problem, he will tell something came and went. Something came and went, I don't know what it is. That is the answer. And they will do guesswork like for D, they will tell K. That is wrong. Okay, so O and this thing. Sometimes the confusion happens between, mainly between O and D. P and R maybe sometimes, okay. So like that, if that happens, then you tell it is foveated, so it is right. Okay, you are questioning whether they foveated or they did not foveate. The VOR is gone, they will not foveate. It's as good as that. Is that okay? A very simple test.
O,
O.
S,
Good.
J,
Yeah. See, one half character appearing also is there.
R, O, N, J,
Super sharp.
Yes.
Done. So this is the horizontal canal, right and left horizontal canal working. Okay, simple. Imagine caloric test. Just to tell right horizontal, left horizontal working, you need to work for 1 hour. And in between make the patient vomit and all that. Okay.
Left hand.
Yeah. So left anterior, that thing comes there. Okay. Yeah. That's done. You can see sir here.
yes, sir.
So this one here, the movement is very important here. Okay. So people generally try to do this one. This is wrong. Okay. This is wrong. This movement is wrong. Or they do this movement. This is also wrong. This is the left anterior plane, and it has to move like this. How do you get it right? Two things to guide you. There is an arrow mark on top of the arrow mark has to write a straight line like this. When it goes up and down, it has to shoot. This is a laser beam. It should shoot a line, straight line up and down. Is that okay? That is the most important thing here. Two key things here. The person, 2 or 3 things. First and foremost, if the person is a spectacle wearer, you have to do the test with the spectacles. With the spectacles. Second thing is, keep this right. This canal plane should be correct. Third one is large arcs. In B hit, the arc is very small. Like this. In F hit, the arc is very big. Like this. Like this. You smoothly get into it. So it's more comfortable for the patient because you don't make small jerky movements. It's a big arc, huge arc. You should use a big arc, smoothly get into that velocity. And then come back. That is the important part. Keep this large arc, smoothly get into the arc. See, horizontal, we'll remember. But vertical, we'll again forget and start doing like this. So again, all the time, you have to maintain a big arc. Okay? Fine. So let us start. So, let's start. So,
N,
yeah. Okay. See, with spectacle also, he is able to see. People will tell with spectacle, that vision, this vision. No. The character appears when he is looking straight to the center of his lens. Is that right? So that is why this is. So I do this.
C,
Good.
V, F, K, L, O, F, J, R, K, O, C,
That attention span.
R, V,
So that left posterior is tested. Is that okay? Now I will show that.
Left hand.
Right posterior. Right. The left anterior is tested. Right posterior. Again, same plane. I come like this. Okay.
N, T, C, I, F, L, K, H, R, O or D,
Anything is okay.
H, V, P, O, J, V, D, S,
Excellent. So you saw this appears. You take a 240 fps camera from one side. You project that. You project the head movement and see. The character will appear exactly at that peak moment of the elastic. That is why this device took 5 years to develop is this, to get the timing right. Okay. Now he comes in. Sorry. This one. No problem. That is attention span. That is okay. Sorry, your phone. That is okay. You can adjust the spend. I do that in a better. This actually, the screen should be at the level of the head. That's it. So that is the. Now I made the adjustment for that screen. So now I need the zoom that screen. So now I learned about that small adaptation. Because I was moving the head exactly like the TV is in front. Now I made it. No problem. No, sir, the TV is right. So now I good. Excellent. But once in a while, this is a test which requires person's cooperation, so 3 times. Person does have a problem, it will always be the red zone. 1, 2, 0, 1, 2. That also, again, sometimes the head suddenly stops, they will be able to detect the character for that reason. Otherwise, it will be 0 scores most of the time. If you are getting somewhere around 5, 6 like that, that means there is something wrong with the technique. Then you have to revisit the technique. That's all it is. Either you get 0, 1, 2, or you get 8, 9, 10. In between means you revisit your technique. Okay, that is all it is. Okay. This is like yes or no answer about semicircular canal functioning. So all the 6 semicircular canals are written. So it is written right anterior canal. What does it test? It tests the right anterior canal. In addition to testing the right anterior canal, it also tells you the full pathway. Along with right anterior, it also tests the right superior rectus and left inferior oblique muscle. Here, right horizontal canal, along with the right horizontal canal, it tests the right medial rectus and left lateral rectus muscle. Here, so you don't have to remember which canal supplies which muscle in the canal, in the eye is being supplied is written in the report only. In addition, here the report tells all the scores are there, normative, normal it is written. Test the reflex arc starting from right horizontal semicircular canal going to the right medial rectus and left lateral rectus muscle. This is the importance that you are actually giving a neuroanatomical diagnosis. Okay, if somebody has a multiple sclerosis, you will be able to tell. So FIT also will tell you about multiple sclerosis, these things. Even sir was telling about mesenteric vamp yesterday, which is the test which will test the C-vamp is also there. Mesenteric vamp also is there. In cervical vamp, the pathway is different. It is the in the neck, the spinal anterior horn cells is the motor pathway. Whereas in the mesenteric vamp, it is the motor nucleus of the trigeminal nerve. If you do a 2-2-2 test, okay, like that. So many things you are testing. It is not just one thing that you are testing. You are testing so many things. Something happened to the TV, projection. Gobi or Raymond is So this is the functional impulse. You saw the things. So the key thing in the functional impulse test that you need to know is project office.
Yes.
Fine. So now I will just go back and show something more about this question, about this particular thing. So what you saw here, I told you about horizontal canal. When you are seeing the horizontal canal, you can actually expand this, okay, and see the kind of times the stimulus came here. Okay. So when the stimulus came, this thing. So you can exactly see the timing of the stimulus here for each of the canals, okay, for each of the projections. So this is the time when the stimulus appeared, just before the peak, just at that time. Then it appeared during the peak. It appeared at this point, means for 40 milliseconds it was there during the peak only. After that it did not appear. Second thing is, it's also a test of your skill, whether you are testing only the horizontal or some other canal. Okay. Now because of the TV projection, you are seeing this amount of the other two canals being stimulated. Otherwise, that also should not be there. Is that okay? So you are testing that. So if you see left anterior, you can see which canals are getting stimulated. Again, this is the other one is participating just because of the height of the TV. I have to change the head height. Otherwise, it will be only one line that will be moving maximum. Okay, it will be moving only one line will be moving maximum. Is that okay? Here, this blue line, okay, this red line. Okay, what you are seeing. Is that okay? So only one line should move maximum. So this can also serve as a test for you to fine-tune your technique, that thing being this. This one because of the TV, otherwise this will be much lower, the other canals. Only the canal that you are testing will be this. Here the red line is for LARP, so LARP, this is the maximum projection. You can see that. So if you see both are equal, then it is wrong, your technique is wrong. Is that okay? So I will show that to you. So this is the other one. I'll just show that to you how that looks like, so that you learn what exactly this is about. Okay. I want you to see this. Okay. How the graphs look like. Okay. How the graphs look like, I will just show you. So I just please pay attention. Maybe you can record this. What exactly happens? Okay. So see the green. When I make a pure horizontal movement. Okay. When I make a pure horizontal movement. You see that? Green line, correct? Okay? So when I make a pure LARP plane movement, only the red line will move. Can you see that? Yes. Vertical canals are getting excited. And the other side vertical canals inhibited. This one, pitching, both anterior canals are getting excited. And both posterior canals are getting excited for this. Anterior, this one, posterior, this one. This one, right side vertical canals excited. This one, left side vertical canals getting excited. Just by looking at this is a beautiful tool for you to do research, to study what is getting stimulated in that particular time. You want to make a rehabilitation, you come up with a rehabilitation program, you see what exactly is happening, which canal you are getting stimulated. So much is there in this. Okay? If you get a person with a tremor, head tremor, you want to record. That also later on you can measure, like that additional thing. Somebody's hand comes with a tremor, you take it, you ask him to hold it in their hand. And then you can measure. Additional, like people gave you first, what is that, ABR, then you only started with ABR, only started doing WEMS now, by just setting the set, like that this is. Whatever you want, you can do additional things. Okay, so like that additional things that you can do, but basically this is repeated. So once you get the practice, you can finish this in 10 minutes. Okay, I was giving a demo and all, still it was rapid. Correct? By the time skin preparation is done, by then your test is over. Correct? No? The test is really over. So to that extent, and then you get a very important information about 3 end organs. In 10 minutes, you get 6 end organs, 3 on the right and 3 on the left. If you do an audiometry, yesterday I was telling about the information that you need as an audio vestibular professional. What is the information you are going to get? First question that you are going to answer is, are the 6 end organs working? In that, PTA will tell you about the cochlea, WEM will tell you about utricle and saccule, and FIT will tell you about the 3 semicircular canals. Working, not working. Next question, is there a debris in the canals? That can be answered with very simple thing by doing a positional test with or without instruments. Okay, 80% without instruments, okay. Another 20% extra. Yesterday Swaroop was having a lot of pain in explaining to the doctors there that why you should be doing it with ENG to get the actual patterns there. Okay. So the positional test. That is the next one. Okay. So that is the next. The last thing is, question is there any bony dehiscence? Is there any bony dehiscence in the OT capsule anywhere? How are you going to answer that question? You are going to answer that question with bone conduction, I mean AV gap with your audiometry and with your WEMS. With your WEMS, with very high thresholds at very low levels of stimulation, or thresholds which Sujit sir told me yesterday about getting the thresholds at higher frequency, at 2K, 4K, okay, where you don't get in a normal person 4K threshold. If you start getting 4K threshold, then again the report should be written as OT capsule dehiscence. If you simply write superior canal dehiscence syndrome and superior canal dehiscence is not then the doctor will tell you told superior canal dehiscence, it is not there. You write OT capsule dehiscence, which means along with superior semicircular canal, they search for dehiscence anywhere in the OT capsule. It can be posterior canal, it can be horizontal canal, it can be the cochlea, anywhere else. They will just write this. See, if somebody sends to you this many questions, instead of sending a 40-page report, if you write a summary report of 1 paper or 2 paper, questions asked. How are the semicircular canals functional? Functionally intact. 1, 2, 3, 1, 2, 3. Intact. Next, any debris in any of the canals? No debris. The last point you are going to write, any dehiscence of the OT canal, any breach, like in brackets you can write superior canal, posterior canal dehiscences. Then you write, no evidence of any dehiscence found. Only 1 page is enough. But that doctor is going to keep sending. One report you send off a single page like this, the doctor will keep sending cases. Instead, if you fill up with 40 pages of jargon, 40 pages of jargon, and then you write and then you interpret it, nobody will even open it. Because that is not relevant for the person. Next, you can write supporting evidence, summary report, supporting evidence. You write, it should be a big sheet, you should write after summary report, next one big empty sheet like a title of the book, supporting evidence for the summary report. And in the supporting evidence, you put the next 40 pages. Is that right? Then you know that this is how you put it. The first page is all that I need to see. If I have to cross-check, you won't cross-check. All the other waveforms, keyforms, everything. I need to just, first time, second time, you will see the supporting. After that, they will believe you and they will tell, okay, this is good, this person has done this. This is the amount of work. This is clear-cut, actionable information. When you provide actionable information, when this, at least the doctor will tell. What the doctor is looking for is, one is what to do to the patient. With this cutting. Second thing what the doctor is looking for is what to counsel the patient. When you say conductive hearing loss, the counseling, you have to go and listen to the ENT doctor's counseling also how they are doing. When you give conductive hearing loss report, just walk into what the doctor is doing. How the doctor typically will talk. He will take an image of the inner ear from the calendar or from there, something like that. See, this is your outer ear, this is your inner ear. There is fluid in the middle. Or there is a bone that is disrupted in the, like that they will talk. That kind of a talking points you should be able to provide to the doctor. Now if you tell posterior canal is not functional, the doctor, or posterior canal has a debris, doctor will now tell, see there is a calcium carbonate crystal here which is moving, which is causing you problems each and every time you are moving there. Or this canal is not working, that is why in certain head movements you are feeling dizzy or lazy. That is a talking point you are providing to the doctor, the moment you give this kind of a report. So this is very simple, straightforward. Simply telling central, peripheral, avoid that central, peripheral. If you tell central, then peripheral, then central, then what will happen? You will tell, sir, central pathology. Then doctor will think what? Central means MRI, some problem should come. Then you will say, they will do an MRI will be normal. What is the central pathology? Problem here is expectations has to be there. Now when you tell central auditory processing disorder, CAPD, what will come in MRI? It will come normal. Does it mean it is not central? It's not like that. So the problem with the central peripheral is that expectations are not clear. So it is a processing disorder, it is not an anatomical disorder. So avoid, instead of that, you just avoid, tell specific questions. As you gain experience more and more, later on you will tell, sir, this patient last time 2 years ago I saw in multiple sclerosis, same finding I am seeing. Call the doctor and tell, have a chat. I am seeing the same finding today. So why don't you? Then they will do it. It is like that you get with experience. But first and foremost is 80% of the information is very clear. And what information you can clearly get, if you cannot clearly communicate, then we are at a loss. This much information all of us can answer, right? Utricle, saccule, dehiscence, debris, functional intactness of the 6 organs. All perfect. As you improve the progress, as you become better and better, then you will start getting into more and more. The better, then you will start learning. There is a day when you will start believing, no, I need this particular, I need this. That is how, this is the beauty of this extra. But when you start off nothing, the present equipment that you have, with that you can start off answering the questions. If you have barrel, if you can do a clinical impulse test, you can start off leaving the course. The way I told you. Very simple. Then go one after the other, make a rule in your business. If you are a very rich man, buy everything. If you are not rich, just simple rule. One equipment you buy, 50% goes to run your family and your clinic, 50% just goes into a fund, which is going to buy the next equipment. So if you are charging 500 rupees for an audiometry, 250 should be used for running your clinic and to fund your family. Remaining 250 should not be touched. It should be put into another account. Just keep it there. At the moment it becomes 2 lakhs, buy your next equipment. Again, now you start putting, instead of 250, it starts becoming 500 rupees accumulated. Then you buy your next equipment. 2-3 years down the line, you are fully able. There has to be a plan like that, okay, of the growth plan, progression plan. This country is a country of 140 crore people. When a country is of 140 crore people, there is no question of one person being a competitor for the other. There is no question of competition at all. Okay? There are different segments of people. There is a gastroenterologist whose consultation fees is 1,000 rupees. There is another gastroenterologist, Nageshwar Reddy, consultation fees is 30,000. You see that, no? Today, if he is taking 30,000 rupees, in the first 10 years of his practice, he must have seen a lot of patients free. This is the growth of professional. So he is charging 30,000, 11 o'clock, VIP appointment, it is called platinum consultation 30,000. There is one more consultation. So that is 2 lakhs. 2 lakhs. Azim Premji comes in his charted file, sits there for a 15-minute consultation, books that appointment for 2 lakhs and then he does something. You want to reach that stage? That will happen with education today, test testing, because each patient is giving you an opportunity to learn to teach you. So with each pure tone audiometry, if you do the para, if you do all these things and then see what is happening, I want to study. Then people will come running to Manchuria, I want this Venu only to see me, I am ready to pay 3 lakh rupees for 15 minutes of it. What Venu? Manchuria.
This is what I am following, sir.
Exactly.
Not going in chart.
That happens with knowledge. You should have seen every pattern. That will happen when every patient you are dealing with. Do everything one another. Call Sujit sir, call Swarup, call Yugandhar, everybody. Because they will all help you. And that is how you progress. Okay? Fine. So I think next is PhD.
Advices as well. Please follow them. Being an ENT surgeon is talking to audiologists and engaging with all these things is a beauty. Thank you, APASLPA.
Yes. And one more test. Champ. And
only
Hyderabad. True. And one more. Glycerol? Right. So is glycerol test widely available today? Is it being accepted? How about CHAM? That equipment is gone actually. Why is that? And also calorics. Do we have calorics? We do. But after hearing amazing insights from Srinivas sir and then Sujit sir, haven't you changed your mind? Or probably haven't you started asking yourself, do I really need caloric? Do I really need CHAM? Do I really need glycerol tests? Things are changing. It's not safe, right? Whatever we are telling you today, we haven't probably had massive when for a couple of years back, sir, we weren't actually talking about it seriously. We only thought like when zero. Now massive is existing and it's real. Right? Things are changing. Whatever we're presenting today will also change. So VA is a big change. And we already talked about positionals yesterday, right? That's most important. So before we get started, I just want to clarify that things, whatever that we're discussing today, will be different next year. It's always best that we keep updated, and that also relevant to your VNG or probably vestibular diagnostics. So today we might be telling you something. It probably, let's say, right, the nystagmus definitely says that you have better performance or better canals on the right side compared to the left side. But there are always caveats. There are always exemptions. In PTA, 0 to 25 is normal, but there is an exemption. It's not true for pediatric population. 0 to 15 is considered as normal. It must be considered as normal, but 15 to 16 to 25 is minimal because there are exemptions. The same way, please do understand that you have to use your pathophysiology. Even though we might say that sometimes it's going to be abnormal, sometimes it can be observed in a normal patient as well. That doesn't mean that you're actually looking at abnormal responses. So just not learning about the tests and how it's being presented, but we have to keep our interpretation mind open to put all those pieces together. So I'll start with that notion so that we can see what I mean and what to eliminate when you get into issues. Because today, after this session, after every talk, you feel like, I got it. Yeah, I'm very professional. I got everything. But once you start testing, once you see results, it's not like what we thought you would do. It changes everything. So that's when take your time. Don't be depressed. Take your time and go back to what you learned from basics, starting from anatomy and everything that we taught you today. So that's how you should approach, because we all want you to be starting vestibular services. Because we definitely have a huge shortage in this sector, and again, as Sir said, there is no competition. It's 140. Believe me, it's more than 140 because people are coming into India, right? So we have to add that. Once you get your name or probably get your services correctly, you're going to get people not only from India, from other countries as well, so we have to add that. Okay, now, so VNG, just for namesake, but position is already done, and I'm not going to teach you calorics today, because I'm a huge advocate towards actually kids. Caloric, as Serge said, it's a 40-minute torture. Even if you're very proficient, I can do it in like 25 minutes, but you're torturing even more, right? And it's expensive, so it's smart investment actually goes to kids, rather than actually going for calorics. Because calorics only laterals, and even it has like a very less sensitivity for other tests. So HIT is going to be appropriate test, we'll be considering generation, so I'm not really going to consider calorics. That's the reason why I'm not going to put that. And positional test has already been covered, so I'm going to start with few things. So yesterday we learned about the anatomy and physiology, right? It goes from there. And positional is going to help us in understanding whether we're dealing with peripheral and central. Again, please don't say peripheral central. We have to be even better than that. So we know how to look into each canal, right, with FFs, vents. Now we know how each canal is actually performing. It's a smart investment. Start with basics. Very simple. As I said, don't go with any equipment. Just purchase a pillow or the smart cushion. That's the first investment. And the first investment, pre-investment is your knowledge. You're here, you're there. So we'll start from there. So when you go for VNG, we expect that we're going to find some peripheral issues, right? VNG, video nystagmography, nystagmus. So what is a nystagmus?
Irregular movement of
Irregular movement, jerk nystagmus, right? Jerk movement. So where does it come from? Why does it occur?
from the brain, from the
Ocular.
hospital brain.
VOR, right? Or probably even some brain issues. It can be midbrain or probably cerebellum, right? So the task is, VNG helps us in differentiating peripheral versus central at the same time. It's going to filter further. It's not just peripheral, central. It's a first filter that has to go through the funnel. Peripheral, okay, what exactly is peripheral? Central, what exactly is central? So that's the smart way to start with. And we had multiple times, like different speakers have raised a question that, or probably comment that there's a gap between audiologist and probably ENT or probably neurologist. A small gap. So what if I tell you, you get these reports, caloric, peripheral weakness, sir. You go there. And always a person that's referring to you need a talking point. Because finally, they who is referring to you, you're not going to talk to the patient thoroughly. You have to give your findings to them and they're going to actually talk about the issues, depending on the diagnosis. They need a talking point. Just saying that caloric is weaker on the left side may not be sufficient. That's the gap that you're going to have. A vent is weaker on the left side. What does it indicate? So with this, if you get all of the teachings today correctly, you have more than enough knowledge to actually fill that gap. So you give more information. So caloric is weaker, or probably forget about caloric. I'm not going to talk about caloric. Vent is weaker. So vent weaker means it can be more than three things. It can be just inferior branch, CV, right? Inferior branch, or saccule deficiency, or probably posterior canal. Is it enough to say that saying that pelvis unilateral or probably asymmetry? That's not enough. Then how do we do? Then invest on HIT. You're going to get precise information, posterior canal, so you can separate further. Same with SSCD, semicircular canal dehiscence. So as Sir rightly said, we have to go a little further. And that's how we're going to get proper diagnostics and proper, at least fill that knowledge. So next time when you actually approach ENTs or probably neurologists, if you share the knowledge, today you might have some reservations saying that, sir, I am finding peripheral issues. That doesn't make any sense. What am I going to do with right peripheral? You have to have more because you have to treat that patient. It's not just giving diagnostic information. So we keep that in mind. So once you gain the knowledge, once you know what you're looking at, you should be able to discuss with your colleagues or ENTs, neurologists, or even general physicians. Then they'll open your mind. As rightly said, they're going to start sending patients to you. Because you're giving enough information so that they can actually explain the patients. Half of the explanation is half of the treatment for vestibular patients. Giving the reason why they have issue is half of the treatment. And the remaining half is just based on our knowledge and the other stuff. Okay, so coming back to VNG. So VNG, we know we're going to actually work on VOR, right? But there is a pre-establishment. As we learn in anatomy and physiology, the vestibular system is smart, it's complex. It works with multiple organs. And when you look at nystagmus, it may not be just from vestibular system, right? So before you get into that, you have to first make sure nothing else is contributing. For example, we all know cars, like four-wheel. When you try to check the performance of car, do we just check, or do we only consider engine? Like a 2 liter or 2.5 liter or 4 liter, whatever the engine is. Like if it goes very fast, let's say it's good. If it doesn't go very fast, or probably steers left or right, that's an abnormality, right? Are you going to check just engine? You also need to have wheels properly. All 4 wheels should have enough pressure and enough performance. There's no tire on it, there's no grip, it cannot, right? The same way, before you check vestibular system, you also need to first rule out any other contributors that may actually give you false information about vestibular system. So that's where the VNG comes in. The VNG, first preliminary VNG is the oculomotor testings. So these are pre-checks. It also gives you a lot of information regarding anything beyond vestibular system. Remember that vestibular issues is not just vestibular system. The balance is not just vestibular system, it's beyond that. So first we have to rule them out. So the first thing is a very, very simple test. And Srinivas sir already talked about this yesterday. Have the patient just keep looking at straight. If even a patient is on bed, have them stand. They definitely have to. They have to, and just ask them to stand and then keep looking straight. And even they can actually sit and then keep looking straight. If you notice any nystagmus, that's called as spontaneous nystagmus, because you're not provoking vestibular system. Just stand straight. Then you see jerks. It can be right beating, it can be left beating, called as spontaneous nystagmus. Now let's go to pathophysiology. What does it indicate? You already had this yesterday. Spontaneous nystagmus, where does it come? Nothing. No motion, no activation on the vestibular system. Conversion, yes. And can it be acute vestibular issues?
Migraine.
Can be migraine. See, we are getting good number of reasons. Yes, these all have to be considered, but predominantly, as I said, there is no one straight answer. There are always caveats, but predominantly, major of the time we see vestibular issues. Straight, even though when there is no vestibular activation, if you see straight nystagmus more than 5 degrees per second, I'll get into that, then it's called as significant nystagmus. Minimum 1 to 2 beats, that's fine sometimes, but that can be significant with other evidences. But anyway, let's say we have nystagmus. We know it's a spontaneous nystagmus. Take that into account. Now you have first piece of evidence. Put it in your pocket. Not pocket, but obviously in your mind. So that tells you, so yesterday sir mentioned that that's a severe or acute phase of vestibular issues, right? The same way, terminologies differ. So don't get into terminologies and don't get yourself confused. I'm going to actually call it as uncompensated vestibular loss. It's same as acute. So in rehabilitation perspective, it can be called as uncompensated. In diagnostic perspective, yes, it's an acute phase or also referred as severe with other evidences. So don't get confused because it's uncompensated because it's completely acute. So that's the first evidence, right? And then you move on to the next one. Because so far we learned that it can be vestibular, it can be brain, it can be probably oculomotor, muscles itself. So sir, equipment is amazing. Not only canals, but sir also showed that the muscles that are responsible, because sometimes it's not just canals. The muscles may also have some dysfunction due to paralysis or probably even vitamin deficiencies, nutrient deficiencies. All these can actually contribute, right? So this is how you're going to take pieces. And that's exactly what gives you evidence. That's exactly what gives you confidence. You have to think about all of these factors. So spontaneous nystagmus, put that. If there is any nystagmus, that's all we're going to see in spontaneous, nothing else. But in here, in spontaneous nystagmus, if you just ask you straight, is it going to be a nystagmus most of the time? If you're evaluating the vestibular periphery, you must block, right? If you give any fixation, any target, that's a fixation. So simple thing is block their eyes. And then probably see if there is some nystagmus. If you have fancy BNG equipment, you're definitely going to have that facility, and you're going to see if any spontaneous nystagmus, you have first evidence. Keep that in your pocket. Let's move on to the next one. Okay, so yes, if there is a spontaneous nystagmus, again it has to be, make a note on degrees. Sometimes it's minimal, can be observed in other reasons for other reasons as well. It can be migraines, it can be sometimes central, it can be peripheral most of the time, but again there are other reasons. But if it is absent, no nystagmus. That doesn't mean that it is normal. But so far, if it is absent, what we know is it's not in acute phase. That's all it is. It's not normal. If there is no nystagmus, it's not normal. It's not in acute phase or semi-compensated. Okay. But if there is nystagmus, there's one more thing that we can do. If we close it, and if you see nystagmus, that can be peripheral. And if you give a fixation, sometimes just open the goggles or give a light if you have a light in the goggles. That's fixation. When you have a target, if it is a true peripheral or vestibular issues, what happens to the nystagmus? Sufficiency. Go back to the sufficiency. So when one system is lost, when you block the vision, you have nystagmus because it's only relying on vestibular system. Now because we have sufficiency, there are like other systems that can contribute by giving a target, just have them look at your finger. Now rather than relying on vestibular system, it's going to rely on oculomotor visions. So now the nystagmus might actually stop. Most of the cases, it might stop. If it stops, what does it indicate? Simple. Now can we confirm, because when we give the target, it's stopping, and now it's depending on this, not depending on vestibular system. Can we say it's peripheral? We can say it is peripheral, right? Because with fixation, which is central, now it's depending on oculomotor, it stopped. But when we take it out, completely block, and nystagmus comes in, simply because it's relying on vestibular system, now we have our first evidence saying that it is peripheral. First funnel goes into peripheral, right? So that's peripheral. Good. So that's the spontaneous nystagmus. Basic test, basic test. Then the second one goes into the oculomotor testing, the first and most important of oculomotors. So you have gaze stability. Yeah, so it's same as the spontaneous nystagmus, open, keep looking straight, that's the first step in gaze stability, and then eccentric positions. Again, Srinivas actually explained it very well yesterday while explaining the hit. So we usually do from center to left or right. And Sadiq mentioned that there are sometimes, even in you, if you didn't sleep enough last night or probably had little alcohol, if we do that now, when you actually go to the eccentric positions, you may have little nystagmus. That can corrupt your recordings, right? We may actually see those things. So most of the time, for vestibular patients, I've seen several patients saying that, so I travel all the way from Vijayawada or probably Vizag to my clinic, all night. Keep this point in your mind. I'm going to come back to that. So if you see eccentric nystagmus, sometimes that can be an issue with the brain, or probably cerebellum, or probably something peripheral. So this is one of the tests that can actually give us information regarding peripheral as well as central, but we have to be very careful. There is no straight answer in VNG responses. Everything has to be put in pieces together. Okay. So in eccentric positions, we're going to ask the client to actually draw their eyes to one end and then to the other end. And we're going to see how the eyes move. Is it going to be smooth, or anything that's apart from smooth is abnormal? It can be square wave jerks, it can be just nystagmus, it can be rebound nystagmus as well. So this is where we're going to get more information. We first entered into big funnel, central versus peripheral. Now we're going to filter it a little more, right? So let's get into that. So positions can go in right, left, up, and down. So it's going to be very helpful. So that's the procedure. I'm not going to talk about those things. Let's look at techniques and then the results. Okay. So what are we doing when we are looking at the responses? So let's say if you're going to ask the client, keep looking to the right, there. And now you're going to see, if you're going to see any responses, I think I have a video, let me show you that. Probably not for this. Okay. So if you're going to see any nystagmus at the corner, it can be, again, remember that it's not always abnormal. You have to go back to the case history. So if someone actually didn't sleep last night, or probably have active migraines, or probably having vestibular suppressants, you may have abnormal responses. But you have to rule them out first. Otherwise it's going to corrupt your responses, right? So keep that in mind. If at all, if you find any abnormal responses, that can actually indicate either peripheral or central. The first one is, let's talk about peripheral, because we already have an example for peripheral. Let's look at the peripheral. So if my patient is looking to the straight, head straight, but only eyes to the right. Remember that we are actually blocking. It's not visual, right? Everything is blocked right now. So you ask them to look right. And if you see nystagmus, let's say right beating nystagmus, let's stick to right beating nystagmus. If we have something, it's not normal, right? By ruling out all those things. Now we have right beating nystagmus. Good, we have something. I don't have enough evidence to call anything. And now we ask them to look at the left side. If there's nothing on the left side, but there is only right beating nystagmus when the eyes are on the right side, but nothing on the left side, what does your physiology say? It's simply called as direction fixed. One of the clues that you can actually carry for your simplicity or probably some cues. Direction fixed. The right side, there is a right beating nystagmus, but when it goes to the left side, nothing. Probably reduced compared to the right side. When does that happen? It looks like always compare. The right beating means the person feels like turning to the right. But left beating, he doesn't move. Little bit. But right side, yes. Think about physiology. This is active. Right side is active. But left side is bad. Nothing. Or probably lows. Peripheral. Probably peripheral because this side is not enough active. Right? So this side there's more exaggeration because on left side it might be a little weaker. So that way, because it's a direction fix, it's only higher in one direction, that indicates that probably the weaker side might be actually weaker. That's your first clue to filter it a little more, right? So if it is central, how does it look like? Because kilomotor does give information regarding peripheral versus central. Simply direction changing. Because if it is peripheral, remember that it has the same consistency, same as Dr. Sujit mentioned yesterday. Even if it is, let's say, there's a difference between BPPVs, vertigo, and Dr. Sujit was mentioning that vestibular migraine. With vestibular migraine, the patients do not talk about consistency. He might get vertigo probably in one position today when he had migraine, but tomorrow when he's completely fine, he doesn't feel vertigo. There is no consistency. Same in central, again, vestibular border spectrum. We're not filtering it out. In central, there might be some direction changing. When it goes to right side, it might be right side. When it goes to the left side, when you ask the client to look at the left side, it might be the left side. Because there is controlling issue. If it is peripheral, it's same. In central, it's a controlling issue. It doesn't control how to block it, how to put everything in straight. So that's central. That's the difference between peripheral and central. Is it clear? And how do we further conform the peripheral? And we had this test yesterday. Sir actually had Roja, I think, here. They had a head shake test, right? It's a simple head shake. You don't need to have on pillow. But you can actually have this guy unseated and then shake their head. With this, continuing with the same example, we had right beating with spontaneous, right? And then the same example, if there is a true peripheral issue, then the gaze eccentric is on the right side. We observe right beating nystagmus. But on the left side, there's nothing or very less. To further confirm, you can actually use, again, just a head shake test. Use head shake test. What do you expect? You have my head shake with a proper and consistent velocity. It's not like keep it consistent. What do we expect? Compare it like spontaneous. Now we have very active movements. Earlier it was right beating nystagmus. Can we expect, because we actively stimulated vestibular system, whatever the response is, there is an asymmetry of response, right? The right side it was already higher because on the left side it's almost nothing. But now you activate. Doesn't these signals go high compared to spontaneous? It does go high. So whatever the responses that you observe in spontaneous, let's say for example, for quantification, in spontaneous nystagmus you have 10 degrees per second, which is high, just exaggerated. After head shake, if it goes to 15, more than 10, 15 or 20, that truly indicates that there is an issue, peripheral issue, that again confirms peripheral issue. Scenario 1, so very typical, you won't see this very often because it's an acute phase. Scenario 2, which you may see more. In spontaneous, you might not notice anything because it's not in acute phase. But in gaze eccentric, you might actually see there is a minimal right beating to the right side. On the left side, you might not see anything. So very minute evidence. You might see like only 4 or 5, 3 degrees per second on the right side, but on the left side, nothing. Usually textbook says that if it is less than 5 or 6 degrees per second, it's insignificant. No. It is insignificant if you only consider this test, but it is going to be significant if you match the patterns. Vestibular interpretation is all about matching the patterns, not just one, right? So in compensated or probably static compensated one, if no spontaneous nystagmus, but if you see eccentric nystagmus a little bit, but in head shake, if you see nystagmus, it probably may not be 10, but even it can be 6 or 7, that you match it to the eccentric gaze nystagmus. Eccentric gaze nystagmus, probably 3 or 4, now after head shake, increased. And these two directions most of the time will be the same. So on the right side, if you have right beating nystagmus, with post-head shake, it has to be right beating nystagmus. Because the responses are truly coming from the better side, so they have to match. If that doesn't match, you're not really looking at peripheral. This is where you get actually confused. And if it doesn't matter, you cannot take that into evidence, because sometimes the gaze eccentric nystagmus can be because of headaches, lack of sleep, fatigue, alcohol consumption, or other reasons as well, or vestibular suppressants. Okay. So that's how you match. So how does it look like in central for gaze eccentric? Direction changing. Remember this term, direction changing. And what about rebound nystagmus? Does anyone know what it is to be called as rebound nystagmus? No? So rather than explaining, let's actually use, see that. Okay. So which side is the eye? This is gaze eccentric test.
Right here, sir.
Left side. Right eye.
Right eye.
This is the right eye. It was looking towards left. Let's replay once again. Okay, now looking towards left side, right? Watch carefully when it comes back to the center. You see that? There is a minimal nystagmus. It's not when it was on the eccentric gaze. That is called as eccentric nystagmus. But when it returned to the center, it doesn't stop there. And actually keep looking at you, when I go this way, I can still see you, right? Because you are exact in my phobia, I can clearly see you. But when the eye comes to the center, if it actually produces any nystagmus, that is called as rebound nystagmus. Can it be VOR related, vestibular related? Can it be VOR related? No, right? Because if it is VOR related, it doesn't actually change on both sides. It will be worse the side is actually weaker. Because in VOR, it depends on the ear that's actually performing very well, but not on the ear that's actually weaker. So if you see rebound nystagmus, it's going to be central. And it does actually indicate any issues that may be coming from midbrain or sometimes cerebellum as well. It doesn't have the control. It's not controlling properly. It's like you steer onto the left side, but it's actually going to the right side. There's an issue at the central, right? If it's a peripheral, it's the thighs are weaker. The thighs are your peripheral system. Left side is left vestibular system, right side your right vestibular system. If it's weaker, if there's a puncture, it usually goes to the right side. You have to pull left side to center, right? But whereas if there is a controlling issue, it doesn't matter. Wherever the signals are weaker, it just goes. The same way the vestibular system can be compared. So if you see rebound nystagmus, it may indicate central. That's another piece of evidence. It's not a confirmative. So you take that into account. Next we move on to the, I think I'm just going to move on because I'm paying a lot of attention here. So I'm going to have this slide sent to you just in case if you need. I'm going to forward this to the APASLPA Association and they can actually have you send this. So this is another example. So the gaze is on the left side, the gaze is on to the right side. You see any nystagmus there?
Yes, sir.
And which nystagmus? Which beating?
Right beat.
Left off right beating, right? So now let's look at this.
Upside beat.
There's a beating, right?
Yeah.
Up. How about now?
No, left side beating.
There is a left beating. So right side, right beating, left side, left beating, upward, up beating. Is it possible in peripheral? No. So what's the problem?
So,
Controlling,
control.
right? So that control will be coming from actually midbrain or probably cerebellum. In this particular patient, it's a cerebellar issue. So that's one of the funnel filtering. So we got that now. Let's actually move on to one more. Okay. So how does it look like in peripheral? Because gaze stability can give you more than peripheral. There might be a couple of scenarios. So in peripheral, let's talk about neuritis, similar to like what we discussed. It will be dashed, it's right beating right. After post-head shake, it will be increasing. But on the left eccentric position, when we ask the eyes to move on to the left side, probably nothing or minimal. Post-head shake, it will be fixed to the same side. But what happens in menias? Because it is still, menias is peripheral or central?
Yes, peripheral.
Peripheral. Just now, we discussed that the right beating would be towards better ear. But again, as I say, in vestibular, there are always exemptions. When we get into that, you should not blame me, you have probably seen yourself. You have to think about your physiology. What if I tell you, even if it is peripheral, the nystagmus can actually go on to the left side, but the problem is on the left side? The answer is within the question. What happens in menias versus vestibular neuritis? So what is vestibular neuritis? Weaker on the side. Now, right? Now, let's say the left side I have vestibular neuritis. Meaning that the sending of signal from the left side to vestibular nuclei is reduced or completely gone. That's the example that we talked about. Now, what if I have menias on the left side? What's the difference? Talk about signals, the amount of activity. Vestibular neuritis, the activity is
Suppressed.
How about menias? Especially when it is active. It's a pressure induced, right? Lot of pressure that can actually activate things more than, even though there is normal on the right side because of my active meniscus and acute phase. It can pressure, it can sensitize the cupula, right? So anytime that you move, because this is not weaker anymore, but this is higher. So in this particular case, you're going to see something called irritative nystagmus, meaning that even though my right side is completely normal, the beating would be to the left side. This is one of the common exemptions that you should be looking for when you are actually looking for meniscus. Yesterday I had a question from one of you actually. How do we clarify that it is meniscus? Do I always need to have ECOGs or probably frequency training events? No, with this simple technique, you can actually look at the meniscus as well. You don't need to have all this fancy equipment. Just to have more comfort or confidence in diagnosing, you can look for irritative. But again, remember that it's only during active phases. Don't blame me that you don't see that when patient feels fine and say that I had an episode like 1 week back only. Now I don't have it. Now you cannot look for rebound nystagmus because it's fine now, right? So that's not rebound nystagmus, irritative nystagmus.
Excuse me, sir. Sir, as you said, example now. So if it is left side vestibular neuritis, so there will be excitation excitation will be low, no?
Yes.
So how it will be signals reach as meniscus disease, sir?
When it compared to the meniscus?
Yeah.
So when there is a weakness on the left side, the excitation is low. Even
Yes.
when you turn to the left side, the excitation is
It will be
low,
low.
right? But with the meniscus, it's not completely gone. It's actually becoming sensitive. Because it's a fluid film, it have pressure on the cupula. It becomes more sensitive. So it's going to be completely contrast to vestibular neuritis. In vestibular neuritis, the response is low. Whereas in meniscus,
Yes,
the
the
response is
response will be
higher compared to the normal side. So when you actually see engaged eccentric or even head shake, you're going to see a left beating nystagmus. But the issue is in left side. Meniscus is on the left side, but earlier, based on the normal pathophysiology, the beating would be indicating towards the better side. Whereas here, it's actually moving to the left side because this is hypersensitive, not normal, but hypersensitive. So this is one of the fine clue that you can actually carry for meniscus diagnosis, along with the ECOG and frequency training events and all. It is called as irritative nystagmus. You can simply say irritative nystagmus. You're giving more talking points to your physicians. Again, you have to consider all patient information, other test results, probably, and see whether they are on vestibular suppressants, had enough sleep, or probably had a lot of alcohol. You don't, alcohol consumption induced nystagmus is really high. Really high. I have at least 2% of my population that have actually alcohol-induced nystagmus. Then you have to ask sometimes, have you had any drink last night? If result doesn't match, again, this my fashion is that after phone call, after interpretation. Okay. So yeah, if it is, and if you have like a vertical nystagmus, as we just saw, if it is vertical nystagmus, it is definitely going to be central, and it can be coming from cerebellar or probably mid-brain. But I'm going to show you this one. There. So observe this pattern. Which beating is it? Down beating, right? It's going fast downwards and then coming back slowly. So that is central, but more precisely observed, most precisely observed in Chiari malformation. The reason that I'm saying this observed, meaning that it can also be observed in other patterns, but clearly or most precisely we observe this in Chiari malformation. You need to think about it. And this is one more. Let's stop this. What do you see?
Left side big.
Little bit of torsional, right? Little bit of torsional, but you're not actually turning your body. What's happening there? Controlling issue again. And this can actually happen in pontomedullary, so medullary issues. Vestibular nucleus. So that's the first test of oculomotor testing, gaze stability. I mean, we had a lot of information, but you have to be clear about looking at peripheral versus central. But when it comes to central, you just now you had funnel. You already clarified that it can be central, but depending on the changes, if it's torsion, you can think about more than central. Now you can think about it can be quantomedullary. It can, if it is just direction changing, upbeating, you can think about midbrain or cerebral. Again, these won't be visible most of the time in MRI. As soon as I say, if you're just going to say central and they're going to send it for MRI, there won't be anything. It can be just functional, it cannot be anatomical lesions. So then, trust on you will be gone. Because they don't have any talking points. So this is how you can slowly grab small evidences for your better interpretations, right? So if it's downbeating, you can think about Carey malformations. Just indicate that it is observing Carey malformations. Good. At least you have some talking points. He can say that, okay, he knows that, okay, I might be looking at this particular anatomical structures or functional issues. Okay, now saccades. Okay, I'm running out of time. Saccade testings. So saccades. Right now, I'm actually looking at all one of you. Right? This is not saccade. When saccade means I have to like move. So this is saccadic movements. Does vestibular system active while we do saccades? Is vestibular system active? No, right? So all these are without vestibular system involved. So I'm not asking my client to move any head, just straight, and then I'm going to actually play a dot or probably anything. There are different equipments, right? Some equipments ask you to follow the dots or probably images and all. So its idea is that you're asking to follow a target. It can be just finger, just bedside evaluation. Finger, not head movement, right? So if there is an abnormality, does it have any involvement of peripheral? Any abnormality in saccades? Meaning that if the patient failed to follow the eye, controlling issue, right? It's not controlling because there is no involvement of peripheral, it's a controlling issue, again going towards central. And there are other parameters to think about. You have to think about velocity as well as the latencies to follow. So let's actually look at those things. So velocity is how fast, let's say this is my eye, and this is the target. If the target is actually moving, let's say 20 degrees per second, the eyes should be able to follow it, just a little bit of lag, but the speed should be almost same. It goes 20 degrees fast. The eye should be able to like follow it properly, almost 20 degrees, right? So if that's the case, then you have proper controlling system, proper central system. If it doesn't, there is too low. This goes fast, but this doesn't go fast. Because vestibular system is not active there. Controlling unit and then eye, oculomotor system, right? So these two are actually working. So if there is something wrong, then there should be something wrong with one of these two. Most of the time it's going to be the midbrain or cerebellum. Okay. So that's the peak velocity. Again, it doesn't show any involvement of your peripheral. And accuracy. So accuracy is like if my target starts from here and goes to, let's say, to here, if my eyes properly reaches exactly to here, that's 100% accurate. Sometimes it can actually overshoot. It can go beyond, or probably just go half of it. That's not normal. The most common is that, let's say up to this extent, and eyes only goes half of it, or probably less than 70% of it. That's undershooting. There might be some pathology involved. But if it goes too high, you have to be very careful, because even though it's not normal, sometimes it can be just because errors. Either we didn't actually take proper history, the patient might be very anxious because of claustrophobia. It does because you're probably conducting this test in dark room or very tiny room. That could actually happen, claustrophobic anxiety, and probably not enough sleep, or probably any other reasons as well, and poor tasking as well. You have to task properly. It happens at the very beginning stage. These are the common mistakes we start with. So overshooting can be errors, but undershooting, again, you have controlling issues. Further evidences for central. Just not one test, because as you see, test errors can actually erupt a lot. So, but more than one abnormal response is gaze eccentric central. Just central in gaze eccentric does not give you enough evidence to call it as central, because that can be just purely other contributing factors. It can be lack of sleep or probably poor tasking, all those things. But if you have more than one abnormality, probably gaze eccentric, direction changing or up beating or down beating, yes, I have central issues. And if you also observe central issues, let's say undershoot or probably low gain in saccadic as well, that's second evidence, right? It's like voting system. Those who get higher votes, they win. Those who don't win. But if it's tied at just one vote, nothing else. So you have to take these into account when you actually come to the diagnosis. Yeah, so overshoot or less hypometria can actually indicate central, but also can actually, you have to make sure that non-lesion factors, medication, fatigue, drowsiness, sometimes calibration errors. So that should be carefully dealt, calibration errors. Okay, so latencies. And, okay, the third one, smooth pursuit. So smooth pursuit is like you have a target, it goes slowly to the one side to the other side, right? And what exactly am I doing? So you actually tried this yesterday. So you know, sir, have you done this? Like he has to actually hold your phone and slowly, once behind the phone, not looking at the phone, and then you actually looked at the phone. So this, you also have smooth pursuits and saccades in it. I'm going to talk about that in next slide. The smooth pursuit is like you actually slowly having your fovea exactly on the target. When you do this, try doing this. Have your finger raised and have it move from one end to other end, but have your target on the finger. But make sure that you don't move your head. Do you actually observe or have any clarity beyond your finger? No. That's the fovea that Srinivasan was talking about, right? So your clarity is exactly on here. You can only do this if your fovea have the ability to actually pay attention on this. It has to be more precise. In saccades, that's not necessary. You may have an, let's say, target. It's not precise. So in here, you have to have complete focus on it to make sure that it's actually moving slowly. In this case, if there is any abnormality, what you're going to see is low gain. Let me actually get my finger. Let's pay attention on this one. Going to the left, it's fine. How about going to the right? So this is going to right. How about going to the left side? You see that? On the right side, it's going smooth. The left side, it's struggling. You have nystagmus and its velocity, the latency is also shifted a little bit. Now let's actually watch the other side. This one. What do you see? Is it smooth? Saccades. It's just moving like, right? It doesn't have the smooth flow. So these two in smooth pursuits give you a lot of information. These two are actually observed in a person with a brain injury. Can also be observed in other factors. So, but depending on the case history. So sometimes I cannot just call central. If I send to physician, MRI completely may actually come with normal, because there is no anatomical damage or probably lesions that can be actually seen in MRI or CT scans. But brainstem or probably brain injury, it's a functional one, so you might actually see these abnormalities in patients. So you have to ask more history in that regard. So this is where, so my faculty taught me in a way that when you're actually conducting test in Putin audiometry, you shut your mouth because you don't want to make any noise, right? Whereas in vestibular testing, it's completely opposite. You're scanning, you spend a lot of energy actually, more than patient. You keep talking. That's what we do. If you run rotary chair, that's a completely different game, but in vestibular testing, based on your actually, whatever the parameters that you observe, let's say if you actually observe right being nystagmus, I don't shut my mouth. Even though I had case history done, now I formulate more questions. Remember the case history? Point one and then expand. If you see any pattern for peripheral, expand it. Again, central. Now I see there's a central pattern. Ask more questions. Do you have any headaches? Do you have any actually history of brain injury? Right? So all you had MRI. So what was the results? So you try to find more information as you test. Yeah, and then the last but one, optokinetics. So the optokinetics are very simple. Yesterday what Srinivas is asked you to do is kind of optokinetics. Either you are rotating, but when you're actually targeting on the phone, right, on yourself, it's actually moving along with you. It's a fixated, moving along with it. It's a visual fixation. But when you actually go beyond phone, you're not really looking at it, but go beyond phone, you don't have a fixation. Even though you have fixations, the targets are different. Your eyes will actually move, right? That's an induced nystagmus. That's completely normal. That's exactly what you're looking at. Usually in testing, there might be a screen and then you might be looking at a dot or probably bars or something, right? You're inducing nystagmus. You're supposed to do it. You're supposed to see that because that's how the function works. But if the nystagmus is completely absent, similar to like you're looking at the phone, but if there is no nystagmus, the gain is zero, close to 20% or 30%. That's abnormal responses once again. So you now have to think about controlling factors, right? So that can again come from your cerebellum or midbrain. So you need to think about those things. I have any examples for this? No. Okay. So these are three important pre-tests to rule out that whether if you're dealing with central or peripheral. Most of the time, most of these tests give you actually central indicators, but the gaze stability can give you peripheral indicators along with the head shake test and spontaneous. Last one, which I don't have slides here, the last one is I need a person. Can I have a volunteer? Take this chair. Have a volunteer for me, please. So this is one test. I'm not going to name the terminology. So I'm holding her, right? You know this test? What are we doing here? Head turn, right? Head turn. What is active? Sorry. Let's say I'm turning our head to the left side. And as far as you can, or probably only 45 degrees, doesn't matter. But which system is actually active? Vestibular. Right? This is exactly what we do in positional and positional, but in supine position. So if you see any nystagmus, we think that it's coming from vestibular system because you're actually activating. Now go back one more system. There's one more hidden and passive system. If you see nystagmus, the misconception is that it is coming from vestibular system. But you have the same test exactly in supine position. But before you go there, you must do this test for two main reasons. Vestibular system is active. How about this?
Colic response.
Colic responses. Someone has cervical issues. You may see nystagmus. If you fail to do this test before you go for any positional test, let's say supine head left, beating, peripheral. Is your diagnosis correct?
Yes.
No, we didn't rule out the cervical. Maybe the cervical issue is actually contributing the responses. Right? So for that particular reason, you must make sure that you actually do the cervical. But is this the correct way? No. The correct way is if you have a fancy chair, do your best. Have the head holding and then turn the chair. So which system are we exactly measuring? Is vestibular system active?
Yeah. No.
Sorry. No, right? We're only activating
Oculomotor and cervical.
and there's one more. So two tests, right? I said two tests. One, cervical. There's one more very dangerous situation where you can get in, and it can actually get us in trouble as well. And you should be very, very careful. You should not do any positionals without doing tests, especially if you're unlucky, the most unlucky is fellow, you might get into this issue. Vestibular insufficiency, vestibular artery insufficiency. There are arteries that actually supply blood to brain, right?
Cerebral arteries.
VBI, vertebrovascular insufficiency. If that is compressed, blocking,
Blood supply to brain.
yes, can result in,
Maybe collapse.
absolutely, we don't want to get into that. It can be severed actually.
Yes.
Very rarely happens, but without doing this test, please don't go for any positional tests. Very important and very helpful. Simple. Try not to actually have turn for the cervical because you're also actually involving vestibular system. Simply just have a chair like this. You're typically looking at cervical or VBI stream. That's it. Simple but very, very effective. Sometimes it can be a lifesaver if you're dealing with VBI insufficiency, VBI patients. So that's the preliminary test before we go for VNG, and then rest of the VNG, positional and positioning has already been dealt with Srinivas sir amazingly, so I'm not really going to get into that. So any questions with this? Again, please make sure that funneling is important, right? Don't go just peripheral or central. Funneling is important. You can have all those things considered and finally give the proper report. And I completely agree with Srinivas sir that the results must be informative. It's not just when is absent on the right side. It doesn't help. There is no point of giving that report. Nothing. There is nothing that the physician can actually get you, and that actually makes your relationship worse. You have to think more than that. At least possible indicators. Only have when. Do SID, sensitive integration of balance. That gives you better information. Just even if you don't have any equipment, go for functional. And if you have like a keen observation, like looking at the naked eye, you can actually get better results. Or try to more practice more and more, best just having the client lay down. You don't need to have fancy goggles at the beginning, right? Charge only like 100 and 500. So exactly, but please make sure that you file a proper summary. You have to have a summary. We did this, and these are the findings, and obviously I'm going to refer these things. I recommend these things so that you know what you're looking at. Because the patient not going to be satisfied with the report, they need treatment, right? So treatment can only be possible once we know proper results and then what can be done. Sometimes vestibular rehabilitation, you have to justify why patient has to go for vestibular rehabilitation but not for vestibular suppressants. Without giving that, you cannot stop vestibular suppressants, right? So, yeah, so that's all about VNG, small portion of my VNG. And if you have any questions, so thank you very much.
Any questions?
And how much time I have after? I'll try finishing all the patients which I have got. Patient 1, the patient is 50 years old female. Came to the clinic with a report of reduced hearing sensitivity. And continuous tinnitus in both areas. It is acquired and progressive in nature, and she also complained of swaying imbalance for hours since 1 year frequently. Other vegetative symptoms which she reported was nausea and sweating. First episode of vertigo, she reported as sweating followed by imbalance 1 year back under medication, but no improvement in her symptom. So when we did PTA, we thought that she had mild bilateral mild sensory neural hearing loss, emittent audiometry revealed no middle ear pathology, and total acoustic emission indicated of outer air cell dysfunction with the left ear. Right ear, OA ear normal. This is the PTA what we got for the patient. As you can see that it is bilateral symmetrical hearing losses. But because the complaint was of vertigo and imbalance in last 1 year, we went ahead with the vestibular testing. And this is the first thing which we got in our report. That is, first we did API, and API on the right hand side was was fine, but left here you can see that there is a between wave 1 to wave 3. It is clearly prolonged. where more than 2 days taken, or where 1 to 3, and that suggested that there is a pathology which is confined within the internal auditory meatus, and probably we suspected of some kind of retrocochlear pathology and probably tumor. Okay. Now what you have to understand here is that yesterday I was telling in my first presentation that auditory neuropathy, your APRs are absent right from wave 1 to 5, and that suggests a peripheral pathology. And I told you that wave 1 and 2 are coming from swan cells, whereas wave 3, 4, 5 are coming from your glial cells. Okay. Now there is a junction of the swan cells and the glial cells, basically wherein the myelin sheath will change from the swan cells and the glial cells, and that area is called as obstrainer Redlich area. You remember obstrainer Redlich area? That is the junction between the glial and the swan cells, and 90% of the vestibular sonomas arise from this junction. And this junction is at the level of cochlear nucleus. If you just want to understand that, that means to say that most of the time in the vestibular sonomas cases, what you will find is latency 1 to 3, latency between 1 to 3 is prolonged. 3rd to 5 you can see is normal, but eventually 1st to 5 will be prolonged. It is clear? So this is the junction. Now we went ahead with vestibular myelin potential. You can see that large amplitude in the right ear. This is 500 Hz and this is 1 kHz. And see what happened with the left ear. Left ear, it was suppressed. The amplitude is reduced a lot. Almost we didn't find the latency change much, but we found that on the left hand side, the cervical ramp, you can see that the amplitude is reduced. And see what happened to the oval. It was completely absent. Left ear, APR prolonged latency. C-wave, it is reduced amplitude. O-wave, it is absent. So all indicating a pathology towards the left side. This is our V-hit result, video hearing pulse test result, and you can see that saccade appearing here. These are the forward saccade which are cleared in this one, and on the left hand side we got reduced VOR gain. And this is another protocol of video hearing pulse test, which is called as suppression hearing pulse paradigm. And on the left side we found that can you see this red color here? This is called as anti-compensatory saccades which were absent here. Okay. And my provisional diagnosis which I made was indication of retrolabyrinthine pathology in left ear, and I said that it is vestibular sonoma. I recommended it for the neurological evaluations and the follow-up. This was my diagnosis, final diagnosis which I made after this one. Clear. Pinpoint diagnosis I have made. This is what my findings are suggesting. Now the patient went for the MRI scan, and it suggests that there is 2.3 into 2 into 2 centimeters CP anal region. Either it is sonoma or meningioma, which is suggested by this. After neurology, what was important? The first point which I picked up was APR latency. First to third, which is very important. Okay, and then second thing was that first to third was prolonged on the left hand side. C-waves were reduced and O-waves were absent. So all suggested that which is there towards the left ear and not the right ear. And because the latencies were prolonged, it is a clear indication that there is some kind of retrolabyrinthine or space occupied lesions. And initially the dizziness started imbalance, suggesting that these tumors are slow growing tumor, so it will compensate over the period of time. So initially they might have a spinning, but at a later stage they will only report of imbalance or a sway that is, they have an imbalance, or sway they will not report of this spinning that everything is moving around. Right? Absence of OE in the right ear and absence of OE in the left ear. Yesterday when I was presenting the pathophysiology, I told you that in the internal auditory meatus you have the labyrinthine artery, and when the tumor will grow big, it will cause a compression of the blood supply, and because of the blood supply, what will happen? The OEs will get affected. Is clear? Now there can be another question that OEs were present in the right ear. Correct? OEs are present in the right ear, but loss is mild hearing loss. But why OEs are present in the right ear? That we should get now. So that suggests that this hearing loss also is not coming from the cochlea. This hearing loss is coming from neural system. Now I will explain you how, from where it is coming. Can you see this displacement of the brain stem? This is what is causing the loss, and that's why the OEs are intact over there. Okay. So this is the first case. The second patient, this is a 9.8-year-old child, okay, and complaint of reduced hearing sensitivity in the left ear. Features of the patient report of him having a speech understanding difficulty that he is not able to understand in the class, acquired in nature and it is progressive. And additional issues which are there is headache and frequent vomiting, So first thing, vomiting associated with headache, first vertigo attack 2 months ago. Vertigo symptoms are recurring once in 15 days. Triggers were changing food habits and exposure to sunlight. But what was important is 2 episodes of syncope at the school. The child fainted and the child was unconscious at the school. Okay, for few minutes the child became unconscious. They admitted him to the hospital and then the child became conscious. This was a big major history which the child presented, and both the speech and motor milestones were reported to be normal. And this is the audiogram which we obtained in the right ear, and this is in the left ear. So left ear also had a sloping hearing loss. Right ear also you can see that there is a high frequency sloping sensory neural hearing loss. Tympanometry results revealed no middle ear pathology. Auditory brainstem responses revealed no retrocochlear pathology. All latencies and amplitude parameters were fine. So by diagnosis at this stage was bilateral moderate to moderately severe sensory neural hearing losses. And when we did all the vestibular tests, apart from a small thing over here, we did not find anything significant here. Nothing significant here. So by diagnosis, I said that the peripheral vestibular system is normal. There is no pathology in the peripheral vestibular system. Otherwise, it looks normal. But the history was important. That is 2 episodes of syncope when the child became unconscious, fainted at the school. So when the child fainted at the school, remember that history of syncope will reveal a severe pathology. It opens many diagnoses actually. Okay, a patient with an inner ear pathology will never become unconscious. Very simple. Menias disease patient will not tell you that I became unconscious. They will say that yes, it was a spinning for an hour, but I knew that everything. I closed my eyes, I vomited, I did this, I did that, but never becomes unconscious. But here the child became unconscious, so I refer the child for a cardiology evaluation and also a neurological evaluation. Now when we did the cardiology evaluation, this was normal, the ECG was normal. When I referred there, they said that, and they did also other tests and they said that cardiology was normal. So the child was again sent to the neurology, and you can see that this. Can you see this? This is nothing but the child has 5.7 into 2.8 into 3.6 centimeter arachnoid cyst in the temporal lobe. Okay, understand that. What was important for me was that 2 episodes of syncope. Is it clear? So next time, when you are asking the patient or taking a history, you have to be very specific whether the patient have become unconscious at any point of time. That opens the door of many diagnoses, and the diagnosis, the whole scenario of the diagnosis can change at any point of time. So here syncope is an important history. Syncope can be sign of a more serious conditions, and this particular patient now will require treatment from the neurology side, and as an audiologist I have nothing to do with the patient. One of the child is not, it may be related to this, may not be related to this. I am not in a position to say that no, this is only coming from this one. But the speech identification, I suppose, as such, it was fine, it was good. So I presume that it is not coming from the temporal lobe, has some additional issues with the cochlear side. Because otherwise he has a good speech identification, I suppose.
Sir, actually, the lesion in the temporal lobe, right? So temporal lobe is, as per I know, it's not taking the vital functions. Then what could be the reason for syncope when there are lesion in the temporal lobe?
Sir, child might have, what I feel is this temporal lobe, this one, what is there is arachnoid cyst, it is compressing. The child might have convulsion of fits.
Okay. So what is the cardiovascular, sir? Is there any?
It's normal. Cardiovascular was normal. Cardiology was normal. This is third case, and this patient was 72-year-old male. Yesterday I was talking about this patient. Complaint of reduced hearing sensitivity, agilitis in the right ear since 4 weeks. Onset was all of a sudden, sudden hearing loss, and administration of anti-antibiotic medication aspirin, but no significant improvement after this. MRI study was done, and this MIT, and the client reported of imbalance for 3 hours during every attack present since 4 weeks, and history of episode of emesis, that is vomiting sensation, present during every giddiness attack, and lightheadedness and blackout at times. PTA revealed right ear a profound hearing loss, left ear a minimal hearing loss. Emittance revealed no middle ear pathology on both the sides, bilateral indication of OHC dysfunction, and ABR site of lesion. Right ear was profound hearing loss, left ear indicated no retrocochlear pathology. This is the audiogram which we formed. So right ear was almost completely dead. You can see the small threshold CNR. Left ear a slight this one, and this you can understand that this may be age-related loss. So high frequency stroking, there is slight hearing loss which is present over here. Now when you look into the result over here of WEM, you see that right ear the waveforms are absent, cervical WEM. Even right ear OWEM waveforms are absent. Left ear waveform, you can see that CWEM is fine. OWEM again it is absent on the left side. Again it could be because of the age factor or because of some cochlear pathology which is present. So this is completely absent on the right side, and you can see that this one, the lateral canal, you can see that on the right side we got good saccade over here, okay, and other gain, right, and this one also the VOR gain was reduced on the right side, which suggested a right side vestibular pathology. And my original diagnosis was vestibular dysfunction secondary to idiopathic silent sensory neural hearing loss in the right ear. Because MRI scan was already done for the patient, and I had the basis that there are no other lesions. So it was safe for me to write that it is vestibular dysfunction only secondary to idiopathic silent sensory neural hearing loss which has caused this one. So I recommended for BRT because the patient had imbalance and then the follow-up. And this case now, this is little different than previously. This is also a sudden onset. Previous one is also sudden onset. So both I have put because you can differentiate both. Mr. B, 83 years male, complained of reduced hearing sensitivity in both ears since 4 to 5 years. So already had hearing loss since long. Complaint of tinnitus in both the ears since 4 to 5 years. Pathological complaint, giddiness and vertigo. True rotatory, occasional, acquired, and it is progressive in nature. Associated problem is sustained headache, which is not coming down. And diabetes under medication for from past 8 years. Hypertension under medication for the past year for hypertension also for 8 years. This is the audiogram which I got for both the years, and patient said that has hearing loss since 4 to 5 years and 82 years old, so you can understand that the client might have hearing loss because of the age factor. Now emittance tympanometry, A-type tympanogram in both the sides, acoustic reflexes were absent, indication of coil, no middle ear pathology. TOE was absent in both the ears, DPOE absent in both the ears, and this was waveform, the ABR latencies which you can see. On this one side, we made a diagnosis of moderate severe hearing loss in the right ear and left ear moderate hearing loss, but vestibular evaluation. The first attack of the vertigo, the client had first attack of vertigo 1 month back. Okay, and one more thing which I would just want to say that sir will agree with me that the first episode of vertigo is very important, because the patient can forget everything, but patient will not forget their first episode. Why? It was their love with the vertigo for the first time. Yes, first love. Yeah. How many of you have forgotten your first crush? You tell me that. Raise your hand. That you don't remember. Raise your hand. Nobody.
We cannot see.
All of you are teachers. Okay. So vestibular dysfunction, description of the first attack, and then had consulted a doctor and took medication for the same, and this was a spell which lasted for about 20 to 30 minutes. And patient reports frequent attacks of vertigo, post that frequent attacks of vertigo after first attack, twice in a week, which lasts for 15 to 20 minutes, followed by a spells of vomiting. So every vomiting this one, episode of vertigo, the patient has this one. Additionally, the patient has dysarthritic speech. This I was talking about that, he had slurred speech and he was trying to place his tongue, and that is what I look upon this case. And upon inquiry, the patient reported that onset of vertigo and problem with the speech are started together. This was very important, which was there, and cervical vestibular migraine potential when we did. Right side it was present, but on left side it was absent, and ocular wave also. Okay, this is the latency and this one. The OM waveform also it was same. Right side it was present, but waveform was not that great. Left side the ocular vestibular migraine potentials were absent. So again left side it was absent. These are the latency and the amplitude value. I am not discussing this. Video head impulse test when we did this one you can see that UR gains were normal on both the sides, and this one corrective saccades were absent. That to say that it indicated that all the semicircular canal were normal and there was no issue at all with the peripheral system. Okay, so impression indication of normal UR gain in all the 6 semicircular canals. This was this one we did results which we got. So provisional diagnosis what I made a little a different diagnosis here. You can see that presbystasis related changes in the vestibular system, dysfunction of sacral and the utricle in the left ear, and then I wrote slurring of speech and sustained headache indicating a probable neurological involvement. This was my final diagnosis, that the slurring of speech and sustained headache which was not coming down for the patient. This is also another important this one, indicating a probable neurological involvement, and then I sent for neurological evaluation and then the follow-up. And got the MRI done, and in the MRI it revealed that the patient has chronic infarct of the right cerebellar hemisphere. Only 2 history here now. One is sustained headache which was not coming down after the first episode of vertigo, and second one that is the slurring of speech which was very evident in the patient, and that is how the whole thing changed. And even the MRI was done, MRI angiography was done, and it says that there is a loss of hyperintense signal in B4 and B3 segment of the right vertebral artery in visualized section, likely to be thrombosis. Further at risk of further stroke. So see that how the diagnosis will change with your small observations which you are going to make in every patient. That is what is very important, that you have to look for that. Sustained headache and dysarthric speech were the key in diagnosing the patient, that the patient has a neurological involvement. Must look for soft neurological signs in the patient. You must learn that what I should look for. Then your diagnosis is very clear, that where you are focusing, and management strategy will change depending upon the diagnosis. Now this patient will require more neurological interventions than any audiological interventions. Clear? Okay. Patient 5.
How was his walking gait, sir?
Walking gait was, he was 82 years, so physical condition was not that great. So it was a wide gait, but I could not make out whether it is because of the aging factor or whether it was because of something which is different in him. But the speech was so evident. Speech was so evident that he's trying to just place his tongue and trying to speak. And when I asked, he said that both started together, but I know next day the speech has become like this.
Struggling to placement.
Struggling to placement of the tongue basically.
Sir, it comes under uprising.
Which one?
Basically, it comes under uprising.
Maybe there is a weakness of the this one articulators when he's just trying to place this one. There was slurring of speech. These are clear speech was there. That is what this one. This case is 26-year-old female and presently complaint reduced hearing sensitivity, ear-long and continuous tinnitus in left ear since 1 year. Okay, and history of first vertigo 3 years ago. 3 years ago, remember that? And episode lasting for how much time? 15 minutes. So it is not in seconds, it is in minutes. Remember, hearing loss now, ear blockage, and now vertigo which is lasting for minutes together. So what does it suggest? From here what do you get? Which pathology? Which pathology? Hearing loss, ear fullness, tinnitus and vertigo. Okay. So this gives you the impression that it could be menias from here before we go ahead with the recent testing. Currently imbalance, sway and lightheadedness also which is present. Complaint of nausea and vomiting during every vertigo episode. And the client will feel well when she will vomit actually. She is dealing with the vertigo, once she will vomit, she will be fine. And then tinnitus intensifies prior to every vertigo attack. tinnitus intensifies. It becomes more. Yesterday you remember I told you that there will be a rupture of the regenerative plate. The fluid will gush out, because of which there will be a movement towards the cochlear side also and towards the vestibular side also. The tinnitus will increase and the episode of vertigo will snap together. Then you see that intensifies. Now also that the client has complaint of phonophobia, photophobia and osmophobia, and complaint of migrainous headache since 3 years, diagnosed with migraine actually, and pain localized towards the occipital region which was there, and it was pulsating in nature. PTA bilateral hearing sensitivity within normal limit and emittance limit, no mediator pathology. OE bilateral, no indication of outer hair cell dysfunction. ABR site of lesion, there was no indication of retrocochlear pathology. You can see the audiogram. You can only see that there is a slight this one which is within normal limit, but low frequencies are coming slightly down here. That's all was there. Otherwise, audiological finding all are normal. There is nothing which is there in this audiological findings. So went ahead with this one vestibular loop magnetic potential, and this is 500 hertz C-wave, and this is 1 kilohertz C-wave. This is 500 hertz O-wave, and this is 1 kilohertz O-wave. And see that everything was fine. There is no problem at all with respect to the wave also. Fine. There is no problem. 500 hertz amplitude is more compared to your this one. But when you look into right versus left, can you see the difference? Amplitude is slightly less on the left side. Okay. Let us see that what is that we got. Okay. Now this is what we got here. In the cervical wave, asymmetry ratio was only 10%. It should be greater than 30%. Let me say that this cyclone was normal cyclophonic pathway functioning. Here there was no problem. But ocular wave, you can see that it was 39%. The O-wave amplitudes were reduced on the left side. This is the only findings which we have got in this case. That's all. There is no other finding which we got in this. Audiology is also normal, except for certain low frequencies coming down. This is also fine here. And only the ocular wave asymmetry ratio is higher. Okay. Now look at the here V-hit results. I'll just put the VUR gain value. Can you see that VUR gain value? On the left side only one of the canal it is affected, other side it is fine, and actually I think both are affected on this side, otherwise everything is fine over here. Okay, reduced VUR functioning in right and left anterior semicircular canal, that's all it is there. Okay, but here there was in the suppression head impulse paradigm again. This was an important finding that the anti-compensatory circuits were not present on the left side, which should have been present. Otherwise, in the normal, it is present. So, my provisional diagnosis was Meniere's disease in the left ear plus migraine associated vertigo. Also, it is there, migraine symptoms, which is also there. Recommendation I made for ENT consultations, neurological evaluations, and then for follow-up. This was my final diagnosis, which I put for this case. Now, another case which was a very simple case basically, very simple case. It is a Meniere's disease, but you will see that a part of wemp coming over here. Patient name was Mr. Krishnamurthy, 38 years old male, and then complained of reduced hearing sensitivity, ear blockage, and tinnitus in left ear since 4 years. History of vertigo lasting for 1 hour 4 years ago. That was the first episode. Vertigo attack reported to occur again 15 days back recently. So this was only the second episode, and complaint of nausea and vomiting during the attack. Right ear minimal hearing loss. Left ear it was moderate sensorineural hearing loss. Emittance no middle ear pathology. OE indicated OSC dysfunction in the left ear. ABR site of lesion. No indication of retrocochlear pathology. This, can you see this? Left ear there is a significant hearing loss. Right ear slight sloping over there. Now you see this. What is that you see? 500 and 1K. 1K amplitude is more compared to 500 hertz. Oh, it was not that great, which was there, not that great in the right ear also, not that great in the left ear also. But see when you see that there was a clear distinction here that the amplitude of 1 kilohertz wave was more compared to your 500 hertz, and that indicated a shift of tuning, frequency tuning of the cervical wave. Yesterday I told you that in the Meniere's disease, because the stiffness of the both the saccule and the utricle will increase, there will be a shift in frequency tuning, and this is very significant diagnosis for the Meniere's disease basically. So vestibular hemochromogenic potentials, here the cervical web and the ocular web presents, and here can you see this saccades which were present on the left side, left lateral canal actually, and here if you see this is the same paradigm which we have done for this one. This is on the right side, which is a normal side. You can see that a large anticompensating saccade, this should come like this only, but here it is absent on the opposite side. Normals you will get this anticompensating saccade on both the sides, now it is absent on the left side. That is indicating that there is a pathology on the left side basically. This is the VUR again, and my provisional diagnosis was by Meniere's disease in the left ear, anticompensating. Very simple case. There is nothing here, that only what I could observe is the shift in the frequency tuning and significant hearing loss in the left ear. And remember, diagnosis and rehabilitation of vestibular disorder always depends upon the clinician efficiency. Never think that I have learned everything. Every new case, new patient is a new learning for you. That way you have to understand. And this will require a team to diagnose the case. 90% of the time it requires the support of other people also. Never think that I have a VNG, I have a WEMP, I have a VH, I have done that, this is my diagnosis and that's it. Nobody can talk about it. There will be that you require the team to diagnose that, and this is what you have to learn. Sometimes I inspire my patient, but more often they inspire me. They teach me a lot. See that just I could tap that the patient has refractory speech and it resulted in some other diagnosis. Okay, that is what is important. Having equipment, yes. Equipment you can buy, but what is that you are getting, that is more important. You have to understand. See, if you have 10 Meniere's disease patient, all 10 are different. That's what you have to understand. Every patient you may not get the frequency tuning. Every patient you may not get the cervical web to be absent. Every patient you may not get ocular web to be absent. You have to understand each case, each patient, and then you have to make a diagnosis. Thank you for being the awesome audience. Thank you so much.
I just wanted to demonstrate. This is the new age video histography. We are calling it COG. COG stands for radio oculography. Okay. It's called radio oculography. It's a video histography and more. Okay. This is how it is. Can you see that? The eye movement. I will show you a lot of things now. Okay, fine. So now, how to just look at the eyes. Okay. Just look at the eyes. What is going to happen? Can you see this? Yes. Okay, you can look at that and figure out whether you are doing it right or not. Look at Excel test. Is it fine? You have to do the Excel test of the opposite side. Keep looking at this and tell me what happens. Can you see that? He's blinking. Don't blink. Can you see the mistake was? Does he have you are seeing this tables, no? In positional test.
But we have to.
Don't blink. Can you see? Okay. So, is that BPPV?
No.
This is per positioning extension. So, during the positioning, everybody will get a mistake. If you don't get it, it's a problem. So the mistake was that is seen after he reaches the position. That is BPP. When the head is not moving. So now when he is doing like this, I go like this down. This you get the mistakes. But now he should not get the mistakes. You got it? Now he is not getting the mistakes. Is that fine? So that is very important point. This is a new age system where head is tracked, eye is tracked. Previously, just to show the head position, they used to have another camera. to set just so what you are doing. And then that camera and the eye camera. Now we have put everything here. So whatever is head position, if it bends forward, you can see it is bending forward. If it looks up, looks up. If it rolls to the right, rolls to the right. Rolls to the left, rolls to the right. Is that okay? So this is the UHVAG system. This is just one position, just for the sake of demonstration that I have shown. Okay. There are so many things that you can do. Sakar test, pursuit test, so many things that you can do with this. Just to demonstrate what it is. What is a VAG about? This is the VAG system. Then there is something else here in the VAG system. Is that in the flap? So closure of the flap. This is what Uganda sir was telling about. What he was telling? No. Removal of the fixation. Okay. On removal of a fixation, what sir was telling is, if the nystagmus enhances, there is one point, in the funneling point, one point in favor of that the inner ear is the problem. Is that right? Okay. So this is removal of fixation. You can see. Now you cannot see anything. Is that right? There is a flap closed. Okay. Now you can, there are some tests like caloric test if you want to do. What you can do is you can actually do fixation. Okay. Can you see something? Red light. So just I can switch on a light there, otherwise you can switch it off. Now it is switched off. Is that right? Yes. No problem. Slowly put your legs down and get on. Straight, 2 steps straight. That's it. So now I am going to reset the head for this position. Just to demonstrate what all is possible. Okay. Now take one full round to the right side. You saw the right breathing nystagmus? Okay. Now you take one full round to the left side. You saw the left breathing nystagmus? Yes. Look to the right. Look to the right. This is eccentric case, which sir was talking about. Then now look center. If you get a nystagmus here and there, and then when you come back, that is rebound nystagmus. Is that okay? So now I will show you something. Turn again. Like it on. Can you see what happened to the pupils? Did you notice that?
Yes.
I will just show you. Okay. Like it on. Like it on. Yes. Just look at the pupils. Okay. Just keep looking at the pupils. Keep looking at the pupils. Did you see that become small? Yes. That is the pupillary response. Okay, there is a pupillary response. Once the light comes, the pupil becomes small. Okay. That's pupillometry. Okay. Cold. Cold response. Fine. So now light is on, correct? Now take one turn. Keep looking at the right. You are looking at the left now. Again turn back. This time the nystagmus was not that robust. Is that right? Normal person will not get even this. This much is getting because light has not slept. Yes. This is VOR suppression. Okay, VOR suppression should not be. Person should not get nystagmus. What is the difference between the first test and the second test? Then also it took 1 round. Then also it took 1 round. What is the difference between the first time and this time?
Remove the fixation.
First time there was no fixation, now he is looking at the fixation LED. The fixation LED is there inside. There is a small light within the flap. It just lights up and then that test shows. I will show you how that works. Okay. So when I remove this flap, do you see the lights here? That light goes through this flap. And then it is shown there. Everybody put one LED here, like they gave one electrical connection here for the fixation LED. We changed everything. We took a toy, you know the toy? Fiber optic. You put a guide, put the light, electronics free flap. Simple, no? Indian engineer. That's now he gets a light. It is very simple. So This is the fixation. Like this, there are a lot of protocols are there. There is Sakar's protocol, smooth pursuit protocol, optokinetic protocol, all those things. And then you can see what happens in the person. Okay. That will need like somebody to see like this separately and somebody to see there that separately. So that also we can do. But I think what we do now, this flight is at 6 o'clock. We will allow you to finish off this presentation. And then we will do that. So you saw how you can do the different kinds of tests. When there is Sakar's, in Sakar's what will happen is same thing is there. On the secondary screen, look here. So this is Sakar's. Okay, something like this. On the screen, the target will appear. Okay, here I want to show you the eyes. That's why I'm not duplicating the screens. In smooth person, it will go like this. Okay, fine. In optokinetic, it will look like this. Turn. It will look like this. Yeah. But in optokinetic, the same target will. Okay, fine. So these are the different types of protocols. I just show you those protocols, how the things are. Relax. I kept it ulta, not that here become like this. I kept it upside down. Okay. You are ready?
So we are sorry, we cannot help ourselves but to break the flow for 5-10 minutes. APSLPA want
So this is how the Sakar's, madam, I have to break your flow for 2 minutes. This is how the Sakar's target moves. The person is asked to look there like that. I just finished now. Sorry. Then there is something called vertical Sakar's. You can understand. Okay. Next is something called nystagmus caloric clinical chair rotation test. There is something. Positional test where you see all these different positional tests that you can do, like the head position, supine row, like all these things are okay. Then there is a protocol called advanced Sakar, which has separate test, and there is a advanced pursuit and pupillometry is there. Then we have the video frenzel mode. Video frenzel mode is where you can add tests of your own, okay, like test 1, test 2. You can go on adding more and more tests, your own protocols if you are not happy with the protocols that are already provided by the manufacturer. Is that okay? So these are all the things that are there. In base test, what happens is the target goes from one place to the other place. So the target is in the center in the beginning, and then after some time it goes to one side, then it goes to the other side, it goes up, it goes down. Patient is asked to fix it there.
I need an answer.
There is more information, very good.
Fantastic,
So how
mind
many
blowing.
shows together?
Big clap.
Definitely they need a standing ovation for
Yes.
the efforts they have. We would like to felicitate them with a small memento. Dr. Vijay sir, if you can celebrate with a small memento. Please accept us from the side of AP. And none other than Dr. Srinivas Garsala sir, who initiated we would like to thank Mr. Sri. Thank you so much, Mr. He gets here points. Thank you so much.
my institute having their own.
The confidence that I am doing vestibular rehabilitation therapy, and believe me, without me you are telling, I am doing voice therapy, speech therapy, all these things. Okay? But here one question is that Yes, there is an observation, we will keep on observing the patient, reassurance and counseling, nothing else. When the patient will, earlier, not right now, earlier when the patient came doctor or somewhere, this was the protocol, they gave medicines, then okay, you will be like this only, somewhere it will be better, maybe the pituitary will come later, like that kind of a reassurance, or it will come again and again, you have to come again and again. Or as sir said, if any medicines, any kind of surgical requirements are there, they have to go for that surgery. And medical, always medicines are prescribed. It is the past methods. But what happened in that past method? The condition is not life-threatening, but the patient will feel that I have to live with this throughout my life. They have that set of mind always. Okay, I have to live with this and this is not curable. People put in Google also, vertigo is not curable, it's manageable. So they are thinking it's manageable, so it's I manage this. So what happened? Don't wish to learn to live with it, but they don't want it. They want treatment, they want cure out of it. That's why they are going here and there, 8, 9, 10 dollars. Okay? But the question here, what is VRT? Is it required for all vestibular, non-vestibular disorder specific? Yes or no? Yes? Okay, we'll see. Next, what are the candidates for VRT? Same way, cochlear implant candidates and other thing. There are some specific candidates which in that case actually you can use the VRT very well. All patients can give, but the problem is that some patients not respond to VRT. We'll see. Is VRT enough for management of vestibular or non-vestibular disorders? If no, then enlist one. We'll see. Next. What is the role of cognition in VRT? What is concussion-based rehabilitation? As said morning, traumatic brain injury, there is a concussion in labyrinthine or in particular area which is not detected by the MRI or CT scan, but that microscopical anatomical changes lead to another level of anxiety, personality changes, lot of things happening. Okay? Mainly those who are football players, they are having all these concussion issues. Now, we have a historical perspective. Since 1940, now exercise has developed. Okay? And if you see, it's not offense, it's actually protocol people are following. There is a chart, in that everything is there, all exercises are there. Doctors are prescribing medicine after that giving that chart. Okay? You take this and do it at home. People are doing it. Some people are doing it. When it triggers, they thought that after doing this exercise, my vertigo triggers more. So they stop. Because nobody is there to guide them what happened next. So, if you see since 1940s to 2000, maneuvers, VTV maneuvers developed a lot. People are doing VRT based on this outcome. But nobody is trying to get involved, particularly for which patient, what kind of protocol we should do. People are doing here and there, all the head position, all settings, standing, all positions. Okay. So now, your answer, the VRT is a systematic, individually designed regimen of exercises and activities that address the unique needs of individual patients. So you have to develop that particular patients for what. Next, it is non-invasive with highly effective approach for patients with vestibular and balance disorder, specifically labyrinthine. As I said, If it is more in utricle, subacute, semicircular canal, labyrinthine issues are there, it will be easy to develop their problem or to overcome their problem. Definitions. So, as from the definition, two important aspects are there. First, you have to understand systematic progression of exercise protocol, which reduce the or extinguish hallucination of motion. Patient always they will see, sir, that true vertigo is not there. But when I am riding my bike, my friend is calling from right side or left side, I am looking there, I am feeling something blurred, something fuzzy. Please do something. I am not feeling confident to ride my bike. So, there are some hallucination kind of things of sometimes. No, I am spinning, something is spinning inside my brain. And exaggeration of motion after motion. Slightly they are doing something and they are telling exaggerated. No, I am facing difficulty day by day. Second, and improves or restores coordination of head and eye movements, balance and equilibrium. So these two things are important when you are looking at the VIP definitions. So what we are actually trying to reduce their hallucinations, or we can say loss of self-motions, and improving their higher coordinations, improving their balance and equilibrium. So these three things we are actually doing. Reducing their dyslexia, improving their confidence, and eye-hand coordination and proper balance. Okay. Benefits of ERP may be the best or only management available, cost effective, non-invasive, short course of therapy, user-friendly, returns or restores everyday functions. Only patients will complain many times what we have observed, sir, I am not physically fit, functionally I am not able to perform my day-to-day activities, my living activities, and emotionally I am miserable. Okay, so for that, scales are there, we will analyze, we have to assess them, what handicapness they are feeling. Even if they are not telling I am handicapped, but what kind of handicapness they are feeling? It's a physically, it's a functionally, it's a emotionally, what? According to that, you will plan your therapy. Why there? Uncompensated vestibular hypofunction results in postural instability, visual blurring with head movements, and subjective complaint of dizziness and imbalance. All these four things the patient will see. First, what is uncompensated vestibular hypofunction will see. Next, due to that postural instability, example I can say. Suppose due to vestibular neuritis or any kind of vestibular hypofunction, suppose this side system is not working properly. So what will happen? In initial stage, acute stage, this system is giving, suppose example case, this system is giving 100 neural pharynx, this system is giving 100, but due to the problem, now it is giving 0 or 10. Then what will happen? The patient will instability or some imbalance issues or what? But rather, after some time, God has made something cellular in the central system, it will automatically detect like which side the problem is there. And they are trying to compensate. Either it could this activity will reduce or this activity will slightly improve. It will be balanced in some way. But if the patient is taking respiratory medicines or other medications for longer durations, then what will happen? That central compensation will not happen. The brain is not getting any information like where to do all these things. That's why vertigo cure, no spinning sensation, but due to that uncompensation, the patient is feeling blurred vision, instability during walking, loss of confidence, and dizziness, imbalance, head movements, then the dyslexia, blurred vision, all these things. Okay, so most people they will tell you, sir, when I am moving my head, I am facing difficult. Otherwise, sitting, walking, no problem. I can manage. Okay. But if it is sensory damage, cannot be recovered back. Okay? If any kind of proprioceptive or any kind of sensory damage due to neuropathic condition or something, then it will not return back. We are not challenging that thing, or we are not counseling the patient also. Okay, we will recover that part. We are working actually on the other end. Vestibular rehabilitation exercise provided good restoration of activities. As it is creating a good restoration, we are actually helping the patient by giving some exercise. So there is no false commitment that okay, I will be making you 100% accurate correctly, you can work, you can do. No. We will make a strategy of individual client-based approach and we will give that therapy. After 21 days, 3 weeks or 1 month, the patient will get confident that okay, I can do this. Why? That is the chicken egg concept. Psychological problem starts early, then vestibular or vestibular system disorder starts first, then psychological problem. No answer. No answer for that. But due to vestibular problem, the patient may develop psychological problem in future. So we are actually targeting vestibular disorders, but the patient is actually developing psychological conditions. So we have to analyze those things, then we'll categorize those patients. Next, what is the goal? Retrain the brain to recognize and accurately process signal from sensory input system that affect balance. So what we are actually trying to give some training to the brain, central adaptations. So what will do? If they are taking longer medicine, you have to make them stop. But few patients will tell, I cannot survive with medicines. So how do you? Counseling, sir. I am here to help you. I will pick up your phone. Don't worry. Even if the midnight you call me, I will pick up your phone. Please believe me. Leave for 1 day, 2 days. See what happens. They will leave. They will say, not enough. But it will not give assurance. They will take their medicine. And they will say, no, I cannot stop, sir. If you want to do something, then do it. Otherwise, do it. And as it is exercise or therapy, how will counsel them? How will counsel them? When patients come for voice therapy, why you are doing all this massage and all this therapy? It is okay. And make your mind voice restoration. Or I'll get my voice 100%. But when you do 2 sessions, they will believe on you. Now my voice is changing. So same way, always counseling. First few sessions will go with the counseling and make them comfortable. Okay, you have to believe on me that he is doing something different on me. He is actually thinking for me and he will help me. Next, okay, helps the brain recognize the sensory input and create appropriate output for the response. As I said, the brain will detect which side is affected, and on that based exercise, it will make a central adaptations. Coordinate appropriate postural strategy in relation to sensory input with respect to the environment. They, according to the environment, according to the functional ability, they can perform daily activities. Same, it will decrease the disequilibrium, decrease oscillopsia, improve functional fatigue and dynamic balance, improve activity level and physical conditioning, and reduce the social isolations. It is very important. Due to vertigo or due to that balance disorder, the patient is not going to any family gathering or any recreational activity and entertainment, no life. I cannot go out of my house. Because they are feeling handicapped. Somewhere they are not feeling good. Okay? And promote activity involved for improved quality of life. Their quality of life is completely affected due to one problem, that is vertigo or some dizziness issues. And we are actually trying to give them therapy without taking it. No. As I said, candidacy for VRT, so we have to check, is this a good candidate for the Western therapy? Okay? Next. So, this is it. You have to understand, VRT mainly divided 2 types, adaptation and substitution. In adaptation, actually what we are trying to do, we are doing a gauge stabilization exercise to reduce oscillopsia and habituation exercise to reduce the vestibular recruitment. Same way, auditory recruitment, same way vestibular. So these 2 exercises are so important. After that, there is a substitution exercise which involves cognition. Because due to that long-term problem, they will have some attention deficit, psychological problem, irritability, frustrated, personality changes, all these things. They'll shout at home also. They call the spouse, hitting, all these things. All these are there. So what you will do? You have to see each and every part. Some scales are there. So scales are there to do certain candidates. How will selection? First, stabilized versus non-stabilized, compensated versus non-compensated, impairment, disability, handicap, related quality of life, psychological assessment. So first, stabilized versus non-stabilized. How will I analyze? What is stabilized, what is non-stabilized? Or unstabilized? Disease is not there. So, patient is stabilized. But compensation not happened. Brain stimulate not detected, which side the problem? Non-stabilized, still acute phase is there. They are not cured out of the disease. Clear? Compensation was not compensated, okay. Then quality of life or impairment, handicapness, some scales are there like dizziness, handicap in inventory. Okay. Lot of questionnaires are there. In that questionnaire, you have to assess the physical, psychological, is an emotional and functional. They are like Gary question, simple 21 questions or 20 questions are there. You just tell them to fill up, and from that you will get to know that which handicap is there. Clear? And psychological assessment, if you know how to do all these personality questionnaires and everything are there, you can do it, mental test and all. If you don't know, you can send the psychologist. Now, first one. Stabilized versus non-compensated I already explained. We are not going in so much details. No time at all. Okay. Now, modalities involved in vestibular disease. First, what we do? There are three modalities. First is vestibular ocular reflex, vestibular spinal reflex, and vestibular polyp reflex. I think all faculty have already given you all the information. So now, what we do for VOR is actually controls eye movements, coordination and gait stability during head movements. Vestibular spinal reflex influences postural stability, translated to musculoskeletal system and anti-gravity muscles. VCR, that is vestibular polyp reflex, responsible for signals from the optolytic gravity sensors and neck muscles proprioceptors. If you will work on this three, then what will happen? It will be. Next. Symptoms of impaired viewer. If the viewer will happen, then what will happen? Difficulty in the reading or difficulty in focusing with head movements. Patient cannot do head movements with focusing on target. Next, difficulty in reading signs while walking and driving. As I said, difficulty in side-to-side dead turns. In bilateral vestibulopathy, chewing or eating while watching television very others. Yes, got the idea? So viewer problem, oscillopsia in during head movements. Simple. So what are the protocols to reduce oscillopsia? We will do adaptation exercise, then gaze comprehension. For vestibular, we will work with optokinetic stimulation, vestibular spinal integration. For vestibular recruitment, we will do habituation. Based on complex visual stimuli, treating brain-based neuroscience. We will work on that. If I say 100 kind of exercise, you can work. But what to knowledge all these 100 exercises, but what exercise you can give the patient according to the age, according to the need you have patient. Suppose I will say skipping. It's a good exercise. But the patient is over 78 years. You will say, sir, do skipping. What? I can work, you are telling you do it. Skipping. So, try to understand the concept. You know very well all the different kinds of exercise. According to the age, select what kind of exercise from basic to advanced model I'll do. First, I'll give simple head turn exercise, then head turn with reading exercise, then standing, then head turn exercise. Depends on their body, posture, and their interest also. If that person is not interested to do that exercise, then you will say, no, you have to do that exercise. They will not. In front of you, they will do, but they will not do at home. Okay. So it should be always interesting. And symptoms of impaired BSR, that is spinal reflex, not sure of pottedness, they will have an imbalance, giddiness, impairment of coordinated movements, preference of softness, they will have falls, preceded by UR symptoms that are resolved or improved. Okay, so most probably you can say the summarize UR problem, oscillopsia, BSR problem, imbalance. What approach will do? Substitution, dynamic and challenging surfaces. I'll come. What are that? Multiplane stimulation challenges vision to force further reduction of surface difference. What will do in that case? Dynamic surface, challenging surface, cushion, elevate to stand, simple on the foam surface, then stepping, then head turn, automatically the brain will get a consider compensation. Yes or no? Because you are challenging, you are giving lot of different tasks. Person is doing head turn, same time stepping, and you can add also cognitive task. 3 plus 3, 5 plus 5, any arithmetic calculation, what's your name, what's your all these things you can talk. What happened to your last night, or you are in dinner, you can talk to them, he will give answer at the same time, he is doing all this exercise. But you have to make it interesting. Then they will do. Now, it will reduce your vertigo and dizziness, reduce gauge instability, reduce imbalance, reduce fall risk, and improve ability to focus or concentrate. So, if you are doing all these things, then why do you hesitate this to the patient with a proper chart and proper training? Give a chart, small 5-6 exercise with proper training. Not all exercise in one day. Barriers. Non-movement. The patient is not interested to move. Some lethargic patients are there. People say, sir, you have to do morning work. Evening work is good, sir. Morning work is right? I'm waking up at 9, 10 o'clock morning. All vitamin D deficiency, everything is there, and you are motivating them to do yoga, exercise. Second, pharmacological investors often that they are taking medications for longer duration. You are giving all therapy and they are taking lot of medicines. Comorbid other influences affecting central nervous system plasticity, particularly within brainstem, that is vestibular nucleus or cerebellum, like Parkinson's disease or some extrapyramidal tract problem. You don't know what is happening to the patient and trying to give a lot of exercise. You can do for Parkinson's also a lot of exercise are there, but not rehabilitation kind of exercise. Okay. As I said, how to measure? These are some tests you can search in net. Is it available? Free of cost. You can download it, read what are the information you are getting on these scales. Functional mobility scale test, musculoskeletal assessment test, ABC test, and subject assessment DHL. Okay, these 4 things are available, and other things are also available, ball index and all. But these 4 things are important. Why important? These all people do. You will get a lot of information. Their strength, their ability, their posture, then their physical handicapness, all these things. In one skill, not get everything. All 4 of them. Then cognitive task, as I said, be mental, follow the instruction, process latency. If that test is available, you can do it. Otherwise, stay to psychology. But the psychologist also should know that what exact information you want. Point to do. What is over? Whom over? Point to do. So our topic was what, whom, when, why. So what to do? Central compensation occur within 90 days of loss or dispute. And medicine prescribed for more than 2 years, 3 years. Out of acute phase condition, non-stabilized with non-compensated. These 3 things are important when you are choosing any VIP kinds. So, your maneuvers are also part of VIP. It's over. I think today discussed adaptation, habituation, substitutions. But for balance restorations, you need strengthening exercise, conditioning exercise, all preventions and assisted daily living exercises, or your activity of daily living exercises. Day-to-day activity, they have to do something. They have some that peer to do, but you have to tell them or modify them to work, to do. So their psychological fears will reduce. It will come last if their disequilibrium there, or if it is vestibular is there, these things are here. So in adaptation, what we are doing? Response of central nervous system to a asymmetrical peripheral vestibular disorder. In habituation, we are actually desensitizing the disease symptoms. In substitutions, when adaptation is not possible, then cerebral stroke or cognitive stability we are actually using. Some infant patients are there, they are taking physiotherapy, but at the same time they have some vestibular issues. So we can work from them. With physical activity, we can do simultaneously cognitive. Okay. So go on by one. What adaptation exercise will give? Saccades and octokinetic. Simple saccade activities and also octokinetic movements. You have the system or in octokinetic you can tell the patient to do some activity at the same time, follow that, or sometimes just look at the center. Octokinetic simulation. So different games are there also available. You can do. Next, focusing while communicating. Any object there? You will tell them to focus that, and other things are there. What you will do? Take a chart on the paper, tell the patient to make a point here, look front, right, left, up, down, left. Further point, 7 positions you can do. Then target gauge. Any particular target you can do, will gauge up to an extent. And circle sway, vestibular rehabilitation based or optional rehabilitation based. Circle sway, any kind of obstacles you put here one, there one, you have to go with particular overcoming the obstacles. Okay? And virtual rehabilitation test. Now different softwares are available with the system, like a market shopping or something you can put that dollars, you can do. So gradually you will adapt it to that particular situation. Habituation. First, head movement activity. Second, ball, circles and game. You have seen in terms of this exercise, catching the balls and all these things. Gate with head turns. As I said, walk, read the newspaper, or take 2 cards, just read and walk. Walk and read. Very difficult. Initially they will not do, but gradually they will do. Okay? And substitution exercise. Easy static, one gym ball, one stool you can use. In that gym ball, tell the patient to just move like this. Okay? And tell them to stand. Simply you can gradually, difficult dynamic surface, you can tell them to stand on a trampoline or any cushion. Okay? And easy to difficult vision related activities you can take. One leg stand, balancing board activities, we'll see. Cushion, balancing board activities, you can do different balancing board. This is balancing board. This one. Okay, it will move. So they have to maintain the balance. And the cognitive task. This is a card you can develop also. Green, but it's written BLU blue, but the red color. So tell them just simply in a trampoline, make that 2 cards, they will do this and read. We'll ask next one. So they will say, either it will say, tell the color or the green, they will say red or the blue. Sometimes they will do wrong. Okay, because it's totally different. They will read it. So what we will do, short-term memory recall activities, complex movement patterns, mathematical things, and questions. These are different cognitive tasks you can give according to the patient's education and knowledge. And for body, lot of things are there. Strengthening exercise, like the patient should stand like this, back supported, this kind of activities should stand first. Then weight direction activities or strengthening activities, sleeping with back raising activities, all these things can be. Now the point is that it's an active work for physiotherapists or for us. Many times people ask me, sir, these things physiotherapists will do now. You can tell them to do the balance activity. At least do the adaptation, how it is now, substitution. Some people are trained, some physiotherapists are trained, but you don't know. People say directly to physiotherapist, they will do only musculoskeletal activity and body balance activity. So what about the muscular recruitment and musculoskeletal activity? So you do first all these things. If the person needs some strengthening activity or balance activity, you can recommend them to a physiotherapist. If writing need musculoskeletal strengthening activities. Okay. Next, lot of history that I am not going one by one. Lot of activities there. I will share the PPT. If you want, you can read. You can develop your own product. So, what are the take-home message? The brain can't fix what the brain can't see. So, all visual, vestibular, and the proprioception. 3 inputs are there. Work on these 3 inputs. The output will come as a muscle strengthening. Simple. How are you making balance? Suppose I am standing in a bus with my friend. I am holding the rod, talking to my friend. And suddenly, the bus is turning towards the right side. What is happening? My eyes is moving, my eyes is giving information, something is moving. At the same time, my sensors giving information, okay, something is moving. And vestibular also, same time. All 3 things, 3 inputs are giving that something is moving. So immediately that encoding, then encodes it and decode immediately within a fraction of a second. They are telling hold that rod. So I am holding that rod tightly, muscle strengthening activity, and discussing it. Nothing happens. If my all 3 inputs will not work, then what will happen? Simple strategy, work all these 3 input levels. Next, no movement, no improvement. If you say, where you will start the exercise, you can do the day 1 also. In all literature they told after resolving the problem you can start the therapy. No, not. Even with the vestibular neuritis or any vestibular hyperfunction, if the patient is in the hospital also, start the day 1. Okay? Sitting positions, body movement positions, looking right, looking left, looking up, looking down. Start slowly, depend upon their movements. Attention, concentration task is so important. If it won't broke, don't fix it. If you did not measure it, it did not happen. So measure, then do it. Protocol must be interesting, new and proper. That's why when the diabetic endocrinologist doctors are giving all this diet, how many people are following diabetic? 1 day, 2 days, after that, same. If somebody will call you again and again, that's why the app now is so popular, healthy 5 apps and all apps, because they are giving reminder, it's time for drink water, it's time for taking the meal. So people are following it. Because somebody is actually guiding you each and every time. That's why the apps are so popular. Same way, you can do some kind of activity now, avatars also on apps. If you will select that app, it will give you reminder. This time you will do exercise, that time you will do all these things. You know, this time you will take medicines and all. So people are now, due to busy lifestyle, they want somebody to guide. So nowadays it's very easy to develop apps also. You can develop apps and you can help them to do. Some yogic asanas are there which is actually proof of the vestibular patients like Padmasana, Yoga Mudrasana, Vrikshasana, Bhujangasana, Salasana, Halasana, Pranayama and all. Okay? These are proof things. So you can work on this. And this is, you cannot do good for each and every patient, but if you can't do good, then don't harm. If you know, do it. If you don't know, don't do it. Because trial and error will not be good in vestibular patients. Okay? It's not like that Anindra massage will do. Sir, today over, second day, only, okay. People doing one day radical massage, second day, only phonation activity. Third day, some other activity. So you have to first make a proper assessment. This is my patient, this is the candidate. I will work on this particular 10-15 exercise or 10 exercise. 1, 2, 3 exercise. You teach them and they should do in front of you and tell them you can consult after 2 days or 1 day. If the patient is coming from far away, you can give them or you can show them the different videos I am doing. Different videos I am doing, sending their WhatsApp. So these 3 exercises you have to do for this week. After 1 week, please come once. If the patient is nearby, encourage them to come again and again. For that, way you are doing this. Clear? Easy? But try to do, make your own protocol, watch exercise to each and every patient. Clear? Thank you. Yes.
Thank you so much. Any
You
questions?
know, there's a good question.
We give the demo, so we finish the presentation.
Learn equal points. So what to tell new things? Tell me. What you are expecting?
Something.
What you are expecting? Any new things? First tell me, what you learn? Sir has experiments.
Minute muscular changes can be seen with naked eye.
Okay. What actually we are measuring in equipoise or stability? Anybody?
Position.
Like positions.
You want to measure the equations, if you give idea, make one more equipment for
That's
us.
right. Okay. Simply 3 semicircular canals measured by FE, be it visual head impulse test or functional head impulse test. Utricle sacral measured by Obevan, Cedar. Also another event, ancestral. And your visual and vestibular, all ocular, motor and vestibular measured by beams. And what remaining parts is there? Proprioception and vestibulospinal reflex. Proprioception and vestibulospinal reflex. And that is actually measured by your balance, which is necessary for balance. Measured by our stabilometry. Okay, so you have comprehensive idea what test for what target areas you are trying to get. So most probably you know what is homework test? Homework test? What is that? Tell the patient to simple stand with eyes open and eyes closed. Then you can make subtract homework by holding the gaze or standing on a cushion. So just think for now. Stabilometer has a big evaluation procedure and other things, but for now you can only remember it is just an extended version of Romberg test. Objective evaluation, very precise and extended version of Romberg test. Because if I do Romberg test right now and I will sway like this, you have observed, but I have not observed. So observe bias may happen. And what to prove that? You will record it with a mobile and you have to send a video to doctor, sir, this is the homework test. Yes? That can be possible, but how much? What are the exact sway to the right side or left side? Person will do like this, then what is that? Person will do like this, then what is that? Person will do like. So, it is a beautiful tool developed by to assess the extended version of our body posture of that What test for what? This is also explained. These are the three inputs and the output. Okay. Now, so balancing act. What is balance? Balance is defined as the ability to maintain your center of mass over your base of. This is my posture. In fact, this is a posture. This is for, if I am standing like this is my base of support and the center of mass is so perpendicular to each and everything, that I can say this is my center of mass. Okay. So same way, there is needed a equilibrium related to balance. What is equilibrium? If I am maintaining all my postures properly, then I can say I have equilibrium. All equilibrium is perfect. If I am not maintaining my posture, then walking, running or standing, then I can say disequilibrium or imbalanced. Simple. Okay. So posture has a big role for balance. If I am standing always like this is not my proper posture, which is not accepted to society. And you feel like something happened to sir. Sir is standing like this. Why? Something musculoskeletal issue, some problem is there. Right? So now, okay. As I said, balance is a fundamental of my daily living activities, transports, working, driving, recreational activities, stability and well-being. For all that, my balance is so necessary. If my balance is not good, I cannot perform all these activities. Then, these balance components based on steadiness, my symmetry, right side, left side symmetry, and dynamic stability, that is postural control. All three things are important when we are looking at the balance. All things are vestibular, over, gone. Vestibular is over. Now coming to the balance. All patients are not vestibular. All patients are vestibular? Because classifications are not. Dizziness divided into two types. Non-vertiginous and vertiginous. Non-vertiginous, disequilibrium, presyncopal, and lightheadedness. These are different classifications. And vertiginous means vertigo. Vertigo means vestibular. And you are saying I am a vestibular specialist, means you have to work on only labyrinth part. Who will take care of other things? When you have a confident on vestibular disorders and mastery of vestibular specialist, then you should go for balance specialist. You should work on everything, from all body, everything. To understand that, you should read a lot. Okay. Now, as components of balance, that is sensor system, motor system, and central articulations. Same way, for posture, we need everything. Standing, walking, running, sitting, lying, lifting, all these things are coming under our postural control, which is a part of balance. And standing is a static form, and walking, running is a dynamic. Just remember. What does posture do for us? Allow to maintain upright alignment, permits efficient movement patterns, allow our joint loaded systematically, all the ligaments, muscles, everything, what they are actually trying to make us a proper posture. I will go quickly. Okay. Now, just imagine a self-driven automatic driving car, Tesla. What do we need? We need a motor, voice, to move, processor, where to go, sensor to find out the obstacles. So here the motors are muscle and joints, processors, brain, our pyramidal and extrapyramidal tract, and sensors is our vision, vestibular, and proprioception. This is not going anywhere. Always is there, right? So now, to measure this, to understand this, we need 2-point stabilometry, which is a artificial intelligence based computerized posturography. Measure what? Static platform, dynamic postural strategy. Static platform means standing. Standing means static. And dynamic activity means If I stand like this, or walk, or run, all these activities. As in this platform, can you do walking activity and running activity? No. But we can do a different kind of activity. Standing on a cushion, all these activities. Okay? So we are actually challenging our body in a different dynamics of this. So it is an accurate extended homework test which is very precise and objective. As I said, the first sentence of this equipoise. Now why I do this test? To measure static balance control, to measure fall risk factor of older adults. This is the need. Because nowadays genetic populations are more prone to fall in the bathroom and heat fractures are common. Right? To actually measure their balance systems and proper coordinations, you can do a posturography or stability test. To measure compensation, is there any sensory balance problem, or the secondary problem like movement strategy or center of gravity awareness. All these things measurement can be possible in our equipments. Other things are also possible. That's why I told you give me some information, next moments I will be able in this equipments. Now, as I said, showing in which direction, how much, observer bias, upper body mobility, non-instability, need to measure center of gravity, measure of instability, movement of center of gravity, equipoise, and how to judge, sway, need, all these things. This instrument is for this. But we are talking only one. There are 8 to 9 protocols are there to assess our body. But I will discuss only one because that is very important. For our perspective, right now. Okay, now the concept is adequacy, redundancy, and insufficiency. Please try to remember these things. Adequacy, redundancy, and inefficiency or insufficiency. Sorry. Let us concentrate on sensor. What are the sensors? Vestibular, visual, and so concept of redundancy means more than needed for maintenance of balance. People make the person stand. Now what is happening? In eye open condition, vision is intact, vestibular system is intact, and proprioception is intact. So all three things are necessary. So more needed for maintenance of balance, but adequacy means any two. If any two is affected, what will happen? I will fall. My vision or proprioception will affect. Then only vestibular can be stand able to make a balance. I will fall. So two things are necessary. If vestibular system has some error, proprioception and vision should be normal. Clear? But in inadequacy, one sensor available person may fall. Only one sensor is available, other two sensors are affected. That means car will not move, the body will not move, will fall. Okay? And this is the hierarchy: vestibular, proprioception, and vision. So higher hierarchy, vision, then we can make a good balance. But lower hierarchy means vestibular or the problem will take place. Will what come on level. This is stability. These are versus one. Stability is in this slide. Which one? This one. Suppose this is vestibular lower part, this is mid, and this is higher part. Actually, what I am trying to say, if something happened to vision, then at least something happened to vestibular. Proprioception and vision maintain good balance. No problem at all. And gradually you can develop this. But some people are blind, or some people are vision problem. How they are going to balance? Quite big. You have seen how the blind people are actually walking along. If the highest system, vision or proprioception are affected, do not have so it will more uniform.
Vision contributes more than proprioception. Vision contributes more than
Exactly. Okay. Now make a challenge for patient, not each and every person, to only measure the vestibular and vision without a support of proprioception. These are the protocols already developed by sir. Vestibular sensory detach, this is the terminology given by sir only. No any other literature or any supplementary get. Bipedal stance of sensory integration of valves. Bipedal stance is both the legs stand, simple, that is for vestibular sensory detach. But what we are trying to do, first eye open condition, then eye closed condition. Then standing on a foam surface, eye open condition, eye closed condition. Okay? Actually, what is happening? If all two things I am doing and just closing my eye, then what is happening? I am standing on vestibular and proprioception. If I stand on a cushion surface, then what is happening? No proprioception. Then I am closing vision also. Then I am standing vestibular. Then what is happening? It's not easy to stand. If my system is okay, intact, bilateral symmetry is there, I can maintain a slight movements, but I can maintain hands. But if something problem in one side is not happened, if there is asymmetry, I will fall or I will sway to that side and correct. That will happen, no? Suppose this is the weaker side. So what will do? I will sway that side and again correct. That correction also measure by this equipment. And second is escalating motor complexity, that is unipedal stance and tandem. One leg stand, right leg, or left leg, or point to for another. Weight bearing squats, limits of stability, rhythmic weight shift, that is lateral movements. Okay? And this is anterior posterior movements, like all these things are there. We will discuss only one. Tandem stepping and visual reference. People see the literatures, what are the literatures I read. These are the all different parameters to measure when we are measuring stability. Center of gravity, romber quotient, sway pathway, sway area, equilibrium area, total displacement, average velocity degree, left, right, anterior, posterior, and frequency of sway, predominant directions, weight distributions. And what you will believe, I was just thinking, thank you sir, there is no any other option to tell sir, so now we have to add this one. Sir has already given all these things in a system. First, escalating sensory detach, bipedal stance, this is a position part. What is the position? This is the starting sir?
Really start.
Starting, this is the ending. So this completely, this line is showing us how much the position are deviated. This is the normal standing, stable surface is eye closed. This is cushion surface, eyes open, cushion surface, eyes closed. And another beautiful thing, sir, how much area the person has moved or covered. So if you expand it, it will take this or bigger than this. If you open the thread, how much the thread is going, that far distance the person has covered. Beauty, but people say, so what is this interesting in this? For us, okay, maybe we give the information because we are not getting so much into this. But those who are doing research, those who are doing only balance activities like physiotherapy or neuro people, it is fantastic equipment. But for us also very important because we are in the first developing stage. And sir is telling, go explore, do something. And nowadays we are getting beautiful graph in different designs. Will come. The second chart is called position plot. Over.
They are not slept right.
This is time series plot. Okay. How far the time the person has covered. As sir said, this is lateral sway, this is anterior posterior sway. And every time what is normal population also, what we have observed that anterior posterior sway is common. Like in normal stance, also anterior posterior is there. You will see. But in cushion surface, both stance. The person may lateral Next, maximum sway. Which direction the person has moved? The person dominant which direction person is actually swaying or maintaining the balance. Also given in this graph, there is some maximum sway plot, and this is the vestibular. If there is no clue, then what to do? If you know hearing loss, no problem, nothing, he is normal, everything is normal, then why is that? Then this test definitely will give you some information that the problem may be the vestibular or in proprioception. Other tests may normal, but this test is so sensitive. Even if any kind of pathological indications, if the person also stabilized, compensated, this will definitely give you little information. If it's normal, but will give information but not vestibular 100%. So sensitive. Okay. So this is the actually beauty of this test, and this is the frequency. As sir said, sir research also, like every human beings should below the low frequency. Because slowly we are moving, we are not moving like this. Slowly we are moving. But in pathological cases, what to do? They will swell more. Right side, left side, any side, they will swell more. So it will go to the higher side, higher frequencies. Clear? So if it is below the lower frequency 1.2 or 1.8 also, then it is normal. There is only one graph. But all are less than 1.2. But if it is more than 2.3 or 2 or 3, then you can say it's abnormal. Okay? And what compared to this? What is this? Posturography. This is posturography. Although I have not seen those physical. Cost is around 1.8 crores. How many people are going to purchase in clinics? And thanks, sir. Indian line. After done this person in nominal charges. Never thought, sir. I saw developed, I think, in this corona design. Corona person? After that. Will. So,
I just take a small. So basically, the idea here is, so what is done here, I will tell you. There is something called sway referencing. We come to this thing. There is something called sway referencing that is done here. What is sway referencing is? Sway referencing of vision means basically you are trying to tell the person to mislead the person into thinking through vision that the person is actually stable when the person is not stable. How do you do that? I'll tell you a simple example. There is a particular soap factory, they are making soaps. Once in a while, there are some places where an extra papers used to be coming on the packing, after the packing. Now, after removing this extra paper used to come, they had to have a method of removing that additional paper. Then all the big brains brought together all those things. Then what they did is, how to remove this paper? Centrifugation, that method, this method, everything they started. They called it Indians technique, it was in Japan. Then he saw, what are you doing all this? Put one fan, no, the extra paper will go after the back. Correct, put one fan, put one fan, extra paper will simply wash up. Other than before that, how to remove this only paper, the soap, because the paper would come out. They were planning smart equipment. So this one, I showed you in this thing also. There used to be one LED in the front, there used to be electrical connection, all those things, switch on, switch off. We just put one light way there, panel is closed. You get the light in front of your eyes. But that doesn't happen just like that. You have to keep thinking every day. Then after say 1 year, you get that sudden flash of idea. So here what they have done is they have done a very complex thing where how much the person is swaying, they measure in the real time. That measurement is actually fed to this platform motor, and when the person is shaking like this, the front this thing is there, no? What is covering? That also is okay, like that. But there is always a problem of latency. This has to be measured, that motor has to know, everything is there. So it can never be real time. Even if it is like that. Whatever, it's called real time, but then there is always latency, few milliseconds, however fast clinicians who came up with very simple mind. Do you do all these things? Just put one broom around the person, wear a helmet, close it, do something with light. Now whenever the person goes back, that moves with the person. The person goes back, that moves with the person. It's very reference. It is not a broom test, it is done by clinicians. So we thought instead of building so big and then charging you 1.5 crores, make a nice platform, you want helmet. That is where reference. It is like this. So this is what basic idea here is to isolate one another and try to find out that particular test. In the morning we were talking about FIT. What were we isolating? We are isolating one particular thing for testing. What was that? Vestibular. From the smooth person. How did we isolate vestibular from the smooth person? By increasing the speed, increasing the velocity. How did we isolate one ear from the other ear? By increasing the velocity even further. Okay, beyond the inhibitor. Is that right? So the idea is to isolate different things for testing. So what we are doing here is, so you put the slide, that's why I came up, otherwise I wouldn't. Okay, so next thing, so here what you are doing is to isolate each one of those things is what this entire protocol, 6 test protocol, sensory application test used to be called. So now what we have done, we have just do the same thing. We have called two protocols. One protocol is called escalating sensory and other protocol is a visual reference protocol. You do the two things together, you get the same kind of information or a little more information than what you get. Exactly. Okay. So this is the, so here what is happening here is, they are closing the eyes, the second one. That anybody, you will ask the person to close the eyes, they will close the eyes. That is it. Here they are blindfolding the person, just to show, okay, because otherwise it is not easy to show in a diagram that the eyes are closed. So for a diagram, otherwise nobody puts that, they close your eyes. Okay. So this is the surface is fixed. Surface is fixed. Okay. Surface is fixed. Then this is sphere reference surface. Sphere reference surface means again center of gravity has to be projection, center of pressure projection has to be measured and then this has to be moved. Instead what? You take a very nice cushion, is established and then put it. This cushion also, you go front, you go front, you go back, you go back. Correct? No? As simple as that. So that is how you achieve the same kind of information. And we've been using it for quite some time. What Swaroop has been using it for about a year now. Yeah, and I have been using it. So now we have found that this is as good as a platform which is motorized. It is only about continuous thinking every day. You apply these principles in day-to-day practice, you will also come up with so many things. I'm sure so many things you would have come up with better ways of saving on electrodes. You have come up now. Okay, like that. Every day we come up with.
And this is very big equipment. In clinical setups, very difficult to put. Who will give you a single room for only posturography? In hospital setup, 6 by 6 rooms are not available for audiology. Right? So, these small equipments we have developed means serves really actually to use all the equipments in clinics. It should be user friendly and clinical setting. Okay? And this is very important last slide. If only vascular impairment is there, then what to do? Possible treatment of medical and rehabilitation. If vision preference impairment is there, the possible treatment is only rehabilitation. If vision and vestibular both are impairment, then medical may or may not reach, rehabilitation may or may not reach, but lifestyle has impact, more impact on lifestyle. If vestibular and proprioception are there, possible treatments is rehabilitation 50-50, more impact. So lifestyle changes is an important factor nowadays. People are vascular migrate, whole night scrolling mobiles, morning no breakfast, no exercise, nothing, and telling, I'm feeling every day I'm yes.
Going in the car,
Yes.
then they have.
And most people have migraine symptoms and telling, no, I don't have migraine. Headache doesn't, you don't have a headache, that doesn't that you don't have migraine. And it will change your lifestyle, change your diet, without medication also, patients are telling, okay, so first of all, start today onwards, work on your patient's lifestyle change, diet change, If you don't know that, at least read something to give them guideline because they believe on you. And third things for this rehabilitation, along with medication, those are necessary. Blood pressure, thyroid, hypertension, all diabetic medicines are required. They should take. You should not stop on this. But if some medications are not required, as your doctors or neurologists are saying these are not required, you will request the patient to stop and work on the rehabilitation. Okay? Thank you. Thank you so much.
Come. Even his nose also is getting thick sometimes. But that's okay. No, that is because the lighting has to be a little more brighter. Then the differentiation between the ball and your nose will go. Otherwise, it is just based on color. But that's okay. We can still demonstrate what is happening. Okay? Fine. Should I start? Yeah, use. Okay. Close your eyes and start taking high steps. Okay? So you can see on the right side the two balls that are moving. Can you see that?
Both sides.
You can stop. So this is his path, sway path, how we move forward. Can you see that? He started in one place and then he went ahead. So that tracing is coming here. So that is the sway path tracing. Then if he turns right or turns left, that also will be shown here. So finally at the end he started turning a little bit to the right. That is what is showing here. Okay. So like that. The same way you can do multiple tests. Again you can go back. The same way you can do multiple tests like tandem walking test, these kind of things. Okay. So now I just go back to the test, I will make it. If you don't know how to do the test or you want to refresh how to do the test, all that you need to do is just show test instructions. If you click there, that particular test instructions will be there. Like if you want to know how to do underburger test, all that you need to do is just click on underburger and then show test instructions, it will come. This is like intuitive. Whatever you have selected, that test instructions will show. If you want to know how to do on round box, just click on round box and then show test instructions, round box related test instructions show. It's like that. Okay? So for tandem walking, he just needs to walk tandem. Okay. Stop there. When I say, you start off. Okay? Take one step little front. So when I say go, you start doing the tandem walking. Is that okay? Start. This height of the ceiling should have been a little more. So this is his way path. Can you see this? How he did the tandem walking. It's a snake-like path. Little bit of snake-like path, he did the tandem walking. So this is about this tandem walking. Like that you can do different protocols. There are 3 protocols here. What is the advantage of this one over clinical is, clinical also same thing. But here you get a documentation. Like this person turned right this much, left this much. And then you keep it like that. Next time after therapy you can tell, okay, before therapy. This does not have site of lesion utilization. Site of lesion is not there because there are so many factors including dominance which sir was talking about yesterday. Right dominance, left dominance which will tell some person. Like if somebody has already a pre-existing right dominance and the person gets a left vestibular deficit, he will walk straight. Because the dominance and this one is getting cancelled. So that is why you can't use this as a site of lesion study. But it can be a very good prognostic. Like in the day 1, if the person went fully right, after your rehabilitation you can always tell, okay, say you went by 90 degrees to the right or you went this far, you have the graph tracing. After 1 month of rehabilitation, patient will ask. That is what Swarup was telling. If you don't measure the rehabilitation progress, then people don't know what is happening. So if you measure and tell in the first day, this is how you are going, and now you see you are walking straight, then that becomes a beautiful this thing. But it does not have site of lesion validity. Okay, it really does not have site of. People tried a lot to find out whether it has a site of lesion validity under the test, but in spite of all this, it doesn't have a site of lesion. But it is a very good prognostic. You can follow and tell the person, like previously it was like this. This is called craniocorpography. Previously, the older versions of craniocorpography used to be camera based. In the camera-based craniocartography, what used to happen is if you open the book for writing short note, that question, this question will be asked, what is craniocartography? You will find that it is camera-based, it is a dark room, and the floor is lighted up with all airport-like lightings to tell the path like that. And then the person is made to walk, film is exposed, and then on the film, all the tracing comes. Then on that, they write a measurement based on the, all this used to be done for traditional craniocartography. But this one is a light room craniocartography. You don't need any dark room. Very simple, just 2 tracker balls and everything is there. All that you need to do is, for that particular place, some lighting adjustment will be required, some tuning will be required. See, when with my previous tuning that I had done for my my clinic, the ball was not tracking. I just did 2 minutes of tuning for this lighting, and then you see the tracking. It's like that. That kind of tuning needs to be done. That's all. After that, this is all. So this is craniocartography. So we saw all equipment now. Is that right? We saw a lot of equipment.